working, could you wave your hand so that Jake can come and resolve your technical issues? Straight away, we've got lady in the back row there. It's you, Suzanne. Are you? Oh, I thought you needed something.
Fine, can you? Yeah.
Sorry, I thought you needed. And it's really hot, so don't make Jake walk backwards and forwards unnecessarily. You're all right? Well, hang on a moment. Has everybody checked their microphones? Good morning, everybody, and welcome to the Children, Adults, Health and Wellbeing Policy Development and Scrutiny panel. It's obviously a very warm day, so I extend a very warm welcome to you as well. My name's Dina Romero, and I chair this panel. I'm going to go round the room and ask those who are on the panel to introduce themselves to you, and then if you're a speaker, perhaps you could introduce yourself when it's your turn to speak. Thank you. Liz.
Good morning, everybody. I'm Liz Hardman. I'm Vice Chair of this panel. I'm Councillor for Porton.
David.
Good morning. David Harding, Councillor for the Chew Valley Ward.
Good morning, everyone. I'm Michael Orton. I'm the Councillor for Midsummer Norton North.
Hello, I am Councillor Joanna Wright, Ward Member for Lambridge.
Good morning, Kevin Burnett. I'm a professional association representative and a non-voting member of the panel.
Morning, everyone. My name's Leslie Mansell. I'm Councillor for Radstock, Labour and Cooperative Party.
Thank you. Mark.
Good morning, everyone. My name is Mark Durnford. I'm the Democratic Services Officer for the panel. Thank you.
Kerry.
Morning, I'm Kerry Williamson. I provide Scrutiny Officer support to the panel.
So, have I missed anybody who's on the panel? I don't think so. Okay. Could I also ask everybody to keep their phones on silent or turn them off? I know there's news always happening, so but it would be better if we weren't interrupted by it. Mark, could you tell us what to do in case there's an emergency?
Yes, no problem, Chair. So if the continuous alarm does sound, you must evacuate the building and proceed to the assembly point. From this room, you follow the green running person signs to the exit, using either the marble staircase or the main staircase. Please do not use the lifts. The assembly point for this building is the Orange Grove grassed area, just outside Brown's Restaurant, and there is an evacuation chair for use by disabled people who so wish in the corridor outside the Council Chamber Public Gallery. Alternatively, the area at the top of the marble staircase has been designated as safe refuge where persons needing assistance should assemble. Thank you, Chair.
Thank you very much, Mark. Do we have any apologies for absence and substitutions?
Just a few, yes. Apologies from panel members, Councillor Crossley and Chris Batten, and Lucy Baker, sorry, from the ICB, and Caroline is here as her replacement today.
And Caroline's her equivalent in Wiltshire?
Yes, yeah.
Thank you. Okay. Any declarations of interest? Michael?
Yes, it's that the service I work with full-time is funded through the Baines Council and been working in adult social care. So, yeah.
Thank you, Michael. And Liz?
Of the Fair Food Alliance organisation.
Okay. Any other declarations? Great. Right. Urgent business? There's none that I'm going to announce right now. Public or councillor statements. So, Cam Lerner, would you like to make your statement, please? Thank you.
Yeah, thank you. New guidance for service providers from the Equality and Human Rights Commission was presented to Parliament in May 2026. The guidance states that trans people should use facilities that match the sex they were assigned at birth, i.e. trans men should use women's facilities and trans women men's. It also states that a third designated space should be made available for trans people who are deemed too masculine or feminine for their assigned sex at birth. This has significant impact on trans people's health and well-being, both physically and mentally. Trans people are already less likely than the general population to access healthcare due to fear of being mistreated. This will only worsen should they know that they will not be placed in services that align with their gender. The systemic scrutiny and misgendering of trans people will compound any mental distress or trauma that they already experience. Service providers will be responsible for enforcing the guidance by challenging service users who do not conform to gender stereotypes, including cis people who do not appear adequately male or female based on the arbitrary judgment of others. Changes to services will also be required to meet the expectations of the guidance. Services will not be able to provide the quality of care to trans people that they wish to. For example, NHS hospitals are required to provide single-sex accommodation to patients. Bed numbers are already under such high pressure. Creating a third space is not realistic, and assigning a private room to a trans person may be disproportionate for their clinical needs. Another example is in schools. Forcing trans youth to use facilities that do not align with their gender identity or segregating them from their peers. Childhood and adolescent positive mental well-being is essential for effective development. Trans youth are already more than twice as likely to attempt to take their own lives as their cis peers. Enforced alienation at school will only further negatively impact their mental health and well-being. Baines Council oversees the running of 4 schools, has a key role in the development of local NHS policies, and councillors are corporate parents for all looked after children in Baines, with a duty to ensure their well-being. My ask of the panel is that they keep the rights, health and well-being of trans children, youth and adults at the forefront of their mind as they perform their scrutiny roles. This will take the form, particularly over the next few months, of ensuring people do not use this guidance as a tool to discriminate against and further harm those who are already at such high risk. And gender reassignment is still a protected characteristic under the Equality Act. By performing this task, you will be taking a positive step in protecting the lives of the trans community. Thank you.
Thank you very much, Cam. Are you happy to take some factual questions? Okay. Panel, do we have some factual questions to ask of Cam? Joanna.
Thank you, Cam, for your statement. One of the issues that you raise is that trans youth are already more than twice as likely to attempt to take their own lives as cis peers. We have on this committee today a suicide prevention strategy. What would you suggest that this committee looks at in regard to that issue?
In relation to this draft code of practice, currently, hopefully it won't get made statutory by the end of the month, but if it does, I would recommend, instead of creating third spaces for trans people, turning all facilities into gender-neutral facilities, especially in the cases of young people. But then there's issues with that because within the draft code of practice, they state that gender-neutral toilets, for example, must have floor-to-ceiling doors, which might be a safeguarding issue in mental health services, for example, perhaps in schools. I'm not actually sure what the if there's any guidance in schools about whether or not they're allowed to have floor-to-ceiling doors on cubicles, but the guidance makes it very difficult to protect trans people. But there are ways of interpreting it that are less harmful, and one of those is turning facilities into gender-neutral facilities, because then it doesn't segregate trans people from the rest of the population, which is not an ideal answer, but the guidance doesn't leave much room for ideal answers, unfortunately.
Thank you, Cam.
And also we've got our stakeholder governor here in the form of Councillor Alison Bourne, who sits on the NHS Trust. What sort of message would you like to go back to the NHS about how this is going to impact trans people?
I would really encourage anybody who has sway in the NHS to publicly speak out against this guidance, because the current NHS guidance for trans patients is based on self-ID, so people get placed in wards that align with the gender that they state that they are. It does say that there's some situations where this might not be appropriate. However, overall, it's a much more ethical, humane, and also efficient policy. So I would say that, yeah, anybody in the NHS should be speaking out against it, because not only is it taking away the human rights of trans people, it's also going to cause a lot more problems in the NHS in terms of having to build or having to create spaces for trans patients to go when, yeah, the NHS is already under a lot of stress.
Thank you, Cam. Can I just remind the panel to ask factual questions of the statement, and but we will, and also Cam, sorry, could you turn your microphone off when you're not speaking?
Oh, sorry.
That's okay. It's only because the camera then stays on you, whilst another might be, and also the microphone levels, I think, are somewhat distorted. Okay. Right, Leslie.
Thank you very much, Cam, for coming along and giving us a statement. Are you aware, at the last meeting, we had a discussion about the guidance for trans children in schools that Jersey States, that's the Channel Islands, have drawn up. And I did ask if they would share that. They said they will, and that will go to our Director of Children's Services when it comes through. I have chased it, so hopefully we'll get that soon, and hopefully that will be positive. Are you also aware that there's 2 early day motions currently going through? One is about disapproving the HRC guidance, because various organisations that work with trans people are saying it's unworkable. And I would say Friday I was at Taunton Cricket Ground, where there's never enough toilets for women anyway. And what they've done is they brought in gender neutral toilets. That's great. The only thing is that they are separate. They do have a sink in them. You have to wait bloody ages to get in one. And then when you do get in there, some man has left the seat up. They haven't figured out how to put it back down. So, you know, it does have impact, and it doesn't necessarily help. And I think with equalities, it should be about improving things for people, because if you improve for one sector in the protected characteristics, then it usually raises it for others. The other EDM is 1251, is about support for trans community. So are you aware of that, and have you sent that out? Because clearly anybody can write to their MP, and I'm not aware that the Bath MP has actually signed either of them yet. Thank you.
Thank you, Leslie. Also, Cam's MP may not be the Bath MP. Other MPs are available. So, Cam, I don't know if you want to answer some of those questions. I think most of them just required a yes or a no answer.
I wasn't aware of the Jersey Schools document, but I would be very interested to see that when it becomes available. I am aware of EDM 240, which is to scrap the draft code of practice, but I wasn't aware of the second one, so I'll have to look that up. That's very interesting. Vera Hobhouse has not, she is my MP, and she has not signed the EDM 240, but there is currently an open letter with Bath constituents signing it to encourage her to do so.
Thank you very much for the your answers, Cam, and for the questions. I'm going to just make one suggestion. Cam, if we take a copy of your statement and then we will pass it on to the leader of the council that has responsibility for equalities. I believe he also sits on the ICP, which is the partnership aside of the ICB, which is the Integrated Care Board as well. And so those are probably the best mechanisms to actually take on the requests that you've outlined. Okay. And thank you again. Joanna.
Following up in terms of this scrutiny's work plan, this is an issue that is really quite serious. So I just wonder how we can bring this forward and make sure that we don't let go of it and keep asking questions about where we are and what's happening.
Yes, I was just being reminded we will ask the ICB to include it in a future update. Hopefully the next one I think would probably be the best one, because also it will be most timely as well. And obviously, Cam, you're more than welcome to come and either make a further statement at that meeting, or obviously watch it online if you wish to. And thank you, Caroline, for making a note of that request. Okay, so we now move on to the next statement, which is from Nicola James.
Good morning, Chair and members of the panel. I'm Nicola James, the former Public Governor for the RUH. First of all, thank you to the panel for your continued scrutiny and for already taking the critical step of writing to the Secretary of State. This panel has already demonstrated that its remit extends beyond clinical delivery to safeguarding and the democratic accountability, fiscal integrity and employment security of our local public institutions. That is exactly why I'm back. I'm here today to expose a pattern of duplicity. BSW's own internal papers explicitly classify the staff bank privatisation as a significant change. Yet their Chief People Officer, Jude Gray, told this panel on the 20th of May and Wiltshire Council on the 14th of June that it was not significant, using that position to justify bypassing their statutory duty to consult you. She stated that only 15% of workers would be affected and that only workers in their exact role would be impacted. We know that is not true. BSW cannot simultaneously tell their own boards this is a significant transformation and tell elected scrutiny panels it is merely operational. That is not ambiguity, that is deception. Now to the human cost. We know that approximately half of all the bank workers holding substantive NHS contracts are part-time. We know that this group is predominantly women and ethnic minority workers relying on bank shifts to survive the cost of living crisis. BSW has a public sector equality duty. They were legally required to assess this impact before proceeding. There is no evidence that they did. When one of those workers picks up a shift in a different department or grade, they lose their NHS pension entitlement. BSW holds the data on exactly how these roles are coded. They are choosing not to give it to you. This is a backdoor pension cut delivered through a contractual firewall, and it will fall hardest on the most vulnerable workers in our NHS. And here is what the public must understand. When a trust guts the retirement security of essential local workers, it's not saving public money, it's privatising the savings and dumping the social cost onto this council and the local taxpayer. The housing benefit, the council tax support, the social care. BSW is handing the profit to a private equity-backed agency and handing the bill to you. This has been enabled by a governance vacuum. Stakeholder governors appointed by our councils and the ICB are sent board papers and have a statutory duty to attend meetings. These documents were on the public record. As a former governor, I knew what I was looking at and recognised the red flags immediately. The paid officials appointed to do that job failed the statutory duty while the system burned. Swindon's scrutiny has been paralysed by the election cycle. Wiltshire has struggled to grasp its own mandate. This panel is the only properly functioning democratic body across the entire BSW footprint. The go-live date remains 1st of August. I urge this panel to do two things. First, formally report BSW's deliberate misleading of the statutory scrutiny body to the Secretary of State. And second, demand the board disclose the precise number of substantive part-time staff, broken down by a protected characteristic, who will lose pensionable status under this contract. Thank you for taking your role seriously, and please help us stop this before it's too late.
Thank you, Nicola. I will ask the panel if they've got any questions, but I wanted to make a comment now. I'll try not to make it into a statement of my own, which is, it is my intention to send a follow-up letter to the Secretary of State, because we have not yet had a response from the Secretary of State on this matter, and we will pick up matters, you know, that have happened since then, some of the correspondence that we've had from the IUH, and alongside, you know, the issues that you've raised in your statement too. I wondered if you could send us, though, a link to the papers that you referred to, because I think that would be very helpful in that additional information that we want to bring to the attention of the Secretary of State. Thank you. Right, panel, are there any questions that you want to raise of Nicola's statement? Michael.
It's kind of a more general question, but I didn't know if Swindon, Wiltshire and Baines are all taking a slightly different position on the situation that we're in at the moment. Would that impact on how the Secretary of State might react to the letter from Baines wanting them to put a block to the decision at all, do you know?
I can't speak for the Secretary of State, but with...
Hey, Michael, was that a factual question? It felt like more like you were gauging opinion.
Okay, it's both, I guess, because we're talking about the different positions that have been highlighted in that. If not,
Answer
then
as best you can, Nicola.
Yeah. I'm personally concerned that if the only call-in notice has come from this panel, that might be exploited. They might say, well, Wiltshire and Swindon are happy, but the truth is the panel in Swindon has been disbanded because there's been a complete, you know, re-election of all of the councillors. So they weren't in a position to hold a meeting and, you know, receive this information. And Wiltshire, I watched the entire panel discussion and presentations, and I was concerned that, first of all, representatives of BSW had met with them in the days before and assured them that the, I think, Independent Review Commission had looked at everything and assured them that it wasn't substantive, but we don't know what information BSW gave them to reach that conclusion. And secondly, it was really apparent, there were admissions on camera, that the Wiltshire panel didn't even understand their own remit. So I was quite shocked by that. So if the Secretary of State, if BSW represents to them, while it's only Baines that are concerned, the other two are obviously satisfied, you know, that could be misleading. So I think it's important. I'm going to write directly as a member of the public to point this out. But it would be helpful if this panel is able to, as far as it can, at least with the Swindon situation and the elections, point that out. Thank you.
Thank you, Nicola. Liz and then Joanna.
Thank you for speaking and for all your information. I don't think you have mentioned, which we were expecting that the RUH would come back to us on this, about the numbers or percentage of the 100% bank staff that are women. Maybe that's a question I ask of our ICB rep later on. Okay. Yeah. Okay, thanks. You haven't heard. Okay, thank you.
Joanna.
Sorry, thank you. Thank you for your statement. You say in it, this has been enabled by a governance vacuum. Stakeholder governors appointed by our councils and the ICB are sent board papers and have a statutory duty to attend meetings. Can you tell me how many meetings there are a year and how often you get these papers, being a former governor?
Okay, there are lots of meetings, but there are quarterly, 4 meetings a year of the Council of Governors. Attendance of that is mandatory. If we miss 2 consecutive meetings or more than 2 out of the 4 meetings, the hospital trust is required to hold a vote of the Council of Governors to consider exceptional circumstances for that to occur. And they are required to disqualify the governor if they haven't attended and haven't got good reason. In addition to that, we receive papers for all of these meetings. So regardless of whether you attend or not, you receive those papers. They're also publicly available papers, which is why I was able to review them. And it was in the September meeting, which was then again repeated in the December bundle, the minutes of that meeting. So there were two opportunities to see this information and to ask questions. And frankly, it was quite clear when they're talking about the savings and the millions that they were coming from the optimization of temporary staff. That should raise alarm bells. So we are required, we go on trainings, we're told what our responsibilities are, to read the papers, to prepare questions. That's really, really clear. There's a triple aim duty, and I would imagine that the duties for the stakeholder governors, are another layer on top of the triple aim duty for a public governor or a staff governor.
I'm going to ask a follow-up question, which is, that level of governors, are they expected to have substitutes? I was just thinking in terms of a mandatory meeting, which may or may not always be possible to attend.
I don't know whether substitutes would be possible because as being a governor, there's required training modules that we all have to attend. Some of those are compulsory, some of those are advisory. And so if somebody was just coming as a substitute and wasn't mandated in or elected into or assigned to that position, then they wouldn't have completed that and they wouldn't be able to carry out the role effectively.
Thank you, Nicola. I appreciate it. It wasn't necessarily a fair question to ask of you. Joanna, did you have another question?
I also wanted to ask about the privatising of the savings and dumping the social cost into this council and the local taxpayer. I mean, that's quite a statement to make. What are you basing that on?
Okay, if we're looking at the numbers, for example, in Bath, they estimated it would be 15% of bank workers, approximately 400 people that would be affected. In Wiltshire at Salisbury Hospital, they said that would be about 900. But when I looked closer at the wording that Ju Gray, the People's Officer, used for the 85%, she said if they're in their exact role. And exact role means, when they do a shift, it may be that they're working in the same role but in a different department, or in their same department and role but at a slightly lower grade or higher grade. So we need clarity on that because I suspect it would be a far larger number. Also, we know from national statistics that approximately half of the workers that hold substantive contracts are part-time workers, and we know that those part-time workers are predominantly women and ethnic minorities because of caring and other responsibilities. So in terms, if they are missing out on having their full pension, sort of top-ups, that means they are going to be potentially tens of thousands of pounds down in retirement, and that means that they will be looking to their local authority for assistance with housing benefit, with care, with council tax benefit. So that will fall to the taxpayer.
Thank you, Nicola, and thank you for your, as ever, bringing us so much more information. Caroline.
Thank you. I don't know if it's just helpful just to...
Sorry, Caroline, could you just introduce yourself to everybody?
Sorry. I'm Caroline Holmes. I'm the Place Director for Wiltshire for the ICB. And I'm standing in today for Lucy Baker, who's on holiday this week, so I'm representing her and presenting her paper later. But I just wondered if it might be helpful just to clarify that at the Wiltshire Select Committee, the question about writing to the Secretary of State was considered, and the committee voted on that and voted not to take that action. The discussion was largely around what does constitute major service change and whether this change had met that threshold level. What they did also request is that there were regular updates on this change going forwards, particularly in terms of any quality impacts that may occur from the change to the bank employment status of those workers. But I just wanted to clarify one final point, if it's helpful. So those staff transferring into the new bank agency arrangements will still be able to access a pension, but it will be a different pension to the NHS pension. So they will still be able to pay into a pension for those hours that they work. Just one final thing, sorry, just to say they did at the Wiltshire Select Committee also ask us to develop a protocol and some guidance to really give some further clarity between ourselves as commissioners, but also for providers and for the Scrutiny Committee on when a service change should come and be debated here within these environments. So we're just starting to work some of that up, and I'm sure we'll be very happy to share that and work it through with this committee as well, if that would be helpful.
Thank you very much, Caroline. I think that offer would be well received. And I think I just want to give a little bit of a pushback. Obviously, Wiltshire is a different place to Bath and North East Somerset, but if that protocol is expected to cover, all the hospitals within that trust, then I think we should have equal standing in terms of developing that protocol. Leslie, did I see your hand had gone up again?
Yes, thank you. Can I just come back to Caroline? Because I was at the Wiltshire meeting and they were being told different things to what we were being told here in Baines. And we had a letter, which I don't suppose you've seen, dated the 15th of May. It was sent very late on a Friday afternoon, just before our meeting. And it does say in the last paragraph, the new temporary staffing model represents a significant transformation. And we're being told it doesn't. So it's not the same thing. We're being told conflicting information. Wiltshire also did ask for figures, but for next year.
Sorry, Leslie, are these questions for...
I'm just
for Nicola.
going back to Caroline, otherwise I'm going to lose the thread.
Oh, okay, all right, but bear in mind that we have another paper from the ICB too. Okay.
Yeah, so the other thing is around the data, which we've asked for, we haven't had. But are you aware that the equality impact assessment is only a screening template? And what it says in there, there's no figures, so we've got no idea of how many people this is going to affect, because we haven't been given the figures. But it also says there's neutral impact. Now, if there's a neutral impact, there's a great possibility that this is indirect discrimination. So it looks very much like the RUH are not actually fulfilling their public sector equality duty, which they have a legal responsibility to do. And then I'd like to come back to Nicola.
Thank you. I just want to check, when you talk about the RUH, are you talking about the BSW Hospital Trust?
My focus is on the RUH because I'm a councillor here, but clearly the BSW works across the three areas, so I can't, I think, ask questions for them as well.
Okay, it is confusing, I grant you that. Caroline, you might want to pick up some of that now, but if you want to develop the answer more fully, then you can bring that up at your paper when that comes up in the agenda. Okay, so you'll bring up the answers when we come back. Okay, thank you. Nicola, was there anything that you wanted to respond to in the questions that Leslie asked?
I also wanted to raise that there are responsibilities that go just beyond equalities. I think you also signed up to, is it the anchor as well? And I couldn't understand, having watched the full Wiltshire panel meeting, that how, first of all, they asked for regular updates, but basically they didn't ask for review until into next year. By that time, it's too late to unravel what has been done. And it was absolutely clear to anybody that watches that meeting, I'll send it to the panel with the timestamp links, that they did not know what the remit of their panel was. That was deeply concerning.
Okay, obviously we're not here to scrutinise what
sure,
Wiltshire
for sure.
does in their scrutiny session, but thank you. I think that would be helpful. I also wanted to give slightly belated thanks to Leslie also for attending as from this panel at the Wiltshire's meeting as well. Again, Caroline, you might want to pick up on some of those comments in your piece on the ICB. Joanna, is this another question for Nicola? Remember, it's Nicola's statement that we're looking at.
But Caroline has made me raise the question. She talked about how there will be availability for pensions in Wiltshire, but she didn't say at what rate. Do you know what the difference would be, Nicola?
Yes, the NHS pension is 23.7%, whereas the pension contribution with the new private agency provider will be 6%. So there's a 17% difference.
Thank you.
Thank you. Do we have any further factual questions to ask of Nicola? Okay, we can bring up other questions, other points at the ICB's item, if that's more relevant. Leslie.
Yes, thank you for your statement, Nicola. You raised about the Anchor Institution principles. Are you aware that these are set by the Health Foundation? And also that the RUH were involved in an event 2024, which we were as well, where the chief executive said, RUH UMATA strategy makes a strong commitment to the people in our community and to make Bath one of the healthiest places to live and work. How do you think that that will be seen through with this privatisation where money is going to go into Canada, not into the local economy?
Is that a question you can answer?
I don't know very much about the Anchor Institute, but my understanding is that some of the panels, not your panels, have seen, and seemingly the RUH and BSW, are trying to define their remit as, or your remit as an oversight body, just to significantly or substantively impacts the delivery of a health service. Whereas your remit as the panel and the council's remit as part of the, apologies if I'm not describing it accurately, the anchor responsibilities extend far further than that. It's to do with the well-being of your community and employees within the community. So I think that they've interpreted it very narrowly, but their own papers show that they themselves recognise it as significant, but they're choosing to present it just as the service we will deliver will still be delivered by the same people, and therefore it shouldn't impact you. Nothing else to see here, but we know that the impact is much wider than that.
Thank you, Nicola. I believe at our last meeting we asked for an update to come to our next meeting, which I think will be in September. I was just checking whether it's September, October, and we would expect the RUH to come and give us, you know, some sort of sense of how, of the impact, assuming, of course, that we haven't managed to get the decision paused by then. So obviously you're very welcome to attend that meeting too. Thank you. Are there any other questions for Nicola? Okay. Right, I'm going to move us on then to the next item, which is the Cabinet Member update. If anybody wishes to leave at this point, then they may do so. Thank you. And I'll just wait for a couple of seconds. Obviously, if anyone's feeling thirsty, as I said before, it's quite a very warm room. We do have water available too. Okay, so Alison, is there anything you wanted to add to your paper that's been circulated already? Obviously, you might want to pick up some of the points that have been raised in the discussions up to now as well. Otherwise, we'll move on to any questions.
Do you mean in relation to the discussion that's just taken place? Yes. Yeah. Well, I suppose the only update I can give is that at the most recent governors' meeting, which was a week or so ago, which I attended, there was quite a lengthy discussion on this matter with the governors, and there was also an acknowledgement that it hadn't been brought to the governors before, and that was a mistake, and it should have been. And yeah, I mean, it was quite an open discussion. Various views were expressed, and I think everybody felt they'd had their say at the end. And I think probably the general consensus reading the room was that given the financial challenges that the IUH is facing, this probably was a reasonable thing to do. I think that was the consensus in the room. But it was obviously recognised that the process by which the decision had been taken could have been better.
I just wondered also about the point that was made around there being different information that appears to have been given to Wiltshire and to us, whether or not that was considered. It may be, of course, that this is the first time we've heard that it might not have been. But you said that there was an acceptance that things could have been done better in terms of sharing that decision. But I worry a bit that maybe we're going to be treated somewhat differently to other parts of the BSW Hospital Trust's governance process.
I think there was an acknowledgement that there should have been more discussion about the proposals at an earlier stage, both with the governors, and probably it should have been communicated with Scrutiny, although they were very much of the view that it wasn't a substantial service change, so it didn't meet the criteria for there having to be a formal consultation with Scrutiny, but they felt it would have been much better if people had heard about it at an earlier stage and understood the context more. They did say that it had been discussed at all 3 scrutiny panels, which is at odds with what Nicola said about it not being discussed in Swindon. So different views on that.
Okay, perhaps we should do some investigating and just see exactly what's been discussed where. And obviously Caroline might be able to help us with that later. There were various hands that had gone up, so I'll take Liz first, then Joanna. Oh, I think it's going to be everybody. Okay, let's go with Liz.
Thank you. It's good being Vice Chair because I usually get first bite of the cherry. So this is my question, Alison, on the previous discussion, and I think as a panel we do need to find out more information about your role as a safeguarding, as a stakeholder governor. And I would like you to describe for us here what do you think your role is in governance. That's my first question, if you could outline it. And secondly, obviously you're saying that it was not on the agenda that of meetings that you were at, of this idea of outsourcing the bank staff at the Royal United and other hospitals. So I just would like you to elaborate on that a little bit. And it is your statutory duty to report to us what is happening at the RUH, and I can't remember any time you've done this. Sorry to put you on the spot, but just wonder, could you elaborate on that, please?
Okay. So there's the Council of Governors, and the majority of governors on the Council of Governors are elected to represent particular communities, and their role is to hold the non-execs of the hospital to account. So that's the role of the governors. The stakeholder governors, of which I am one, have a slightly different role in that our job is to represent organisations that work closely with the IUH and to ensure that the organisations are working together productively and positively. So that's what my focus as a stakeholder governor has been. And in relation to the IUH, it's been largely about ensuring that we don't have BAIN's patients sitting in hospital when they are medically fit for discharge. And we try to ensure that flow works well. And we also try to ensure that we've got sufficient community services available, that means that people don't get admitted inappropriately as well. And we perform very well as a community on that, and that does get reported in my reports that I provide, and it's also reported by the ICB in their reports. So I hope that clarifies it.
Thank you for elaborating on that with the Chair's permission. So to what extent did you not realise that the outsourcing of the locum, the bank staff, that this was actually going to take place?
It hadn't been discussed with the governors. None of the governors were aware of it because it hadn't been discussed. In some of the papers that have been sent out, there had been reference to the fact that there were significant financial savings targets. And one of the number of ways that they were proposing to make savings was about optimising temporary staffing costs or something of that sort. But that didn't necessarily immediately say we are going to be putting our bank out to tender. And as I said, it wasn't brought to the meetings, it wasn't on the agenda, but the hospital has acknowledged subsequently that it should have been. And as I've said in previous meetings, I was first aware of this, when was it, April, I think, when it was first brought to this panel, and a paper came out on the Friday before this panel on the Monday morning. That was the first I was aware of it.
Okay. As everybody's hands all went up at the same time, and I know everybody wants to speak, I'm actually going to go around the room, so I'll start with David, I think.
Thank you, Chair. Mine aren't related to the bank staff, so I can wait.
All right, so other questions around the hospital and bank staff that people want to raise with the Cabinet member? Joanna and then Leslie.
Thank you. You've just said that the role that you have is working together productively and positively. But this scrutiny meeting only knew about this bank staff issue this April. But there are papers going back to committees that you would have had papers on last September. So I'm just wondering how this is a productive and a positive setting, because at the moment I don't think anybody in this room or when it went to full council were thinking that this was a positive outcome. And a follow-up too is this whole thing about anchor responsibility. Could you elaborate where your role is as a Cabinet member on anchor responsibility, please?
Okay, well, I think I've already answered the first one. It was not explicit in any of the papers that went out that there were plans to put the bank service out to tender. There were statements about financial savings targets, which were very challenging, and one of those things was about optimising the cost of temporary staffing. That was it. So that's that bit. In relation
of asking a question around that in terms of your due diligence.
Sorry, could that be through the chair, please? So can you let Alison answer, and then we will see if there's anything else that needs to be asked.
And in relation to the second one about the anchor institutions, I think that is a concept whereby major employers in an organisation, and often public sector employers, but not entirely, are seen as anchor institutions, and they work together to benefit the community. So I think the RUH is an anchor institution in Bath or in Baines. The council is, the universities are. That's the concept of anchor institutions, and I don't directly input to any discussions there are amongst the anchor institutions. I play a small role as a governor at the RUH in trying to ensure that the services between the RUH and the council work to best effect for our residents.
Thank you. I'm sort of going to slightly butt in, but I think it might be really helpful for us as a panel in future if perhaps your Cabinet report includes something about, you attend the 4 quarterly meetings, I assume. So if you include, you know, an update from those, I think would be beneficial to us.
I attend the full quarterly meetings when I can. Occasionally there are diary clashes and I can't, but I do when I can.
Actually, and that brings me back to that point that I asked of Nicola, I think, about substitutions as well. And perhaps that's something that your meeting needs to consider at some point. But anyway, I'm not running those meetings. Who was next on my list? Leslie.
Yes, thank you. On the RUH issues, if you look on the Baines website, it sets out what stakeholder governors' responsibilities are. And that's to collectively hold the board of directors to account for the trust performance and advise on its future development. And I'm really not clear that this has happened in this case. If you look at the papers from the Council of Governors in December 2025, and they're open to the public, which is how I found them, there is a chart there, and it's quite clear. Within that chart, it says, optimisation of this temporary staffing bank, saving £8.2 million. Now, I have a friend who doesn't have any kind of qualifications at all, and I said to her, what would you ask if you saw that chart? And she said, well, how much is this going to be? Who is it going to affect and where is it going to affect? So were those questions asked? Because as a governor, you would have a responsibility to ask those questions. So we didn't hear about this until our meeting on the 20th of April. And in May, we asked what questions you'd asked. You said you didn't know about it. In May, you said you had asked some panel, and they said it wasn't in the papers. Well, it was in the papers. It may have been hidden, which is not necessarily you know, the stakeholder governor's responsibility, but why wasn't a question asked at that point? And I think for me, it's showing a real failure in governance. And if you look at those papers in December, it already states that there's going to be a preferred provider before it's gone out for consultation with the Joint Union Committee. And then when the RUH came here, they said, oh, we've been talking to the unions, but they'd already decided. So there's no discussion there. And as part of their responsibilities under the Health and Social Care Act, and also under the Anchor Institution, it's about collaborating, working in partnership. They haven't worked in partnership with us here on this scrutiny panel, or in fact at Wiltshire, because I think they only went there because they've been here and thought, we'd better go and have a word with them. So really my question is, what can we do next? And I think we need to be asking for the data now. We want to see what the baseline is, because if this does go through, we want to be looking at it in a year's time so we can properly scrutinise it. Without that baseline data, we don't know, and they've been very chary about giving us that information. And the other thing I think we need to do is ask Alison if she would put in, and she has the, she can do that, if she puts in a governor's concern statement to the RUH, because this is not looking good for Alison, it's not looking good for us. And to be quite honest, I haven't got time to keep going through. It's taken me hours and hours to go through those papers because they're written in a format I find difficult to use anyway. And I can't do it. And surely I would have thought our stakeholder governor would at least come back with some reports so we can have some clarity about what's going on. Thank you.
Thank you. Before Alison comes in, I think some of those questions are very much directed at the RUH Hospital Trust, the BSW Hospital Trust anyway. So I think perhaps we can take those from Alison and direct them there. You know, we did have that assurance from the trust that they would want to work more closely with us and be more open with us. So this would be, you know, a good test. I don't know, Alison, if you want to pick up any of the points that you feel you can address at this point. I mean, it's obviously very difficult to ask questions on something that you didn't know that you were supposed to know about. Because again, I think there's been a lot of well, it definitely feels like a lack of transparency on behalf of the RUH at some level.
Yeah, and I think the RUH has acknowledged that it didn't get the process right. The external process, I feel it says that it did have the correct discussions with staff side, so it did it internally, but didn't do it externally. But I would just reiterate that the role of the Foundation Trust Governors is to hold the non-execs to account. And there are a number of working groups that they have. I'm not involved in any of those working groups. That's the Foundation Trust Governors. The stakeholder governors have got a different role, and that's what I've been involved in. And you know, my remit is too wide to join all the working groups as well. So I have to focus on a fairly narrow aspect, which is what stakeholder governors are expected to do.
Thank you, Alison. And I think what we probably also need is a flow chart of, you know, of the organisation, and particularly around, you know, who sits where and who's doing what. I'm not asking you to do that, Alison. I think we will get that from the RUH.
It's on their website.
Thank you. Well, if we can get that, and then we can circulate that amongst the rest of the panel as well to give us that clarity too. Joanna, can this be the last question on this item?
Sure, but just picking up from what Councillor Bourne said at the beginning, that she attended a meeting and there clearly was a consensus within the RUH committee to, it is what it is and they have to save some money. But this committee has written to the Secretary of State. We are unhappy. It was quite clear at full council that many councillors were unhappy about this. As a cabinet member who sits there and represents us, what has she said to basically to put up our argument that we are not satisfied with this answer, and how is she directing that within her ability to be in those committees?
Alison?
Had discussions with the leadership of the RUH about it, and they know my views that the process was not correct, and they've acknowledged that the process was not correct. So yeah.
Thank you, Alison. I think we'll leave that there, and then we will move on.
Are you going to take the headings?
I'm going to ask people if they want to ask questions. Okay. So we're now leaving the RUH, and I know, David, you had some other questions you wanted to ask for clarification on.
Thank you, Chair. Thank you, Alison. And it may not really be a question for you, and I certainly don't expect you to have an answer today. It may be a question more for corporate, to be honest. But in terms of parks and recreation and the public health budget, how much is spent on Baines 55 parks and play parks on terms of maintenance, equipment, staff, officer time? Where does that money come from, and what funding streams does it come from? And I appreciate that it's not a question you're going to answer today, and it might be for corporate.
Alison, is that something you can answer?
Yes, I don't have all of that information at my fingertips, but I'm sure we can get hold of it.
Thank you. I don't know, Paul, if you wanted to add anything. I think leisure comes under your directorate.
Thanks, Chair. Yeah, leisure does, but the parks are under a different directorate, so we can definitely find out for you, but they're in a wider Sustainable Communities directorate. So happy to try and find out the answer for that.
And that was Paul Scott, who is the interim director for public health.
Yes, thank you. Sorry, I should have introduced myself.
So we're taking questions now on parks and leisure and public health, I think. So Joanna and then Liz.
Okay, I've got a few questions on the whole on her piece. So you just want me to stay with one issue?
Just if we stick to this one item for now, and then we'll come back to those other items, if that's acceptable. Just trying to keep some sense of order.
Okay, so going back to the play motion that was raised at full council, that's been passed. What you've presently given us is a good summary of existing plans and strategies. However, it doesn't sufficiently identify gaps in provision. The review of current provision is clearly focused on green spaces and parks. There is no mention of other spaces like public realm, pavement, play streets, school playgrounds, especially in urban environments. For example, Beasley Maze, is that how you say it? busier. The maze here, anyway, near Pulteney Weir, is a great place. Lots of people play, and that is an issue. How we incorporate spaces. The Bath River line is a huge investment, and they've put a huge investment in Green Park, but actually how many people, families actually access that? So we're putting in green infrastructure, but we aren't always doing it about play, and it's not always in places where people most need it. Have we actually done a map of where we have families, where schools are, and where those places are near to, so that people can get to those spaces? So there's a huge amount of work that we think that needs to be done, and at the moment we just think that this is a bit underwhelming. So I just want to work out how we go from here in a way that is more than just setting out a few spaces in parks.
It might well be that we need a bigger piece of work doing on this to identify and answer all of those questions. But Alison, you can make a start if you want.
Yes, I mean, I understood that we were trying to establish a baseline that would underpin a bigger piece of policy work that might be taken forward by one of the scrutiny panels. So I didn't think that we were expected to answer all of those things at that point. I thought that was the whole purpose of the piece of work.
No, that, as I said, I think this is exactly as you said. It was that first, you know, what do we know so far? And that's what we have before us. So I think we will be asking for a further paper, which may well take a number of months to develop fully. So I'll leave it to Paul to perhaps give us an indication of that when we come to our, what do you call it, the future meetings piece, you know. Yes, work plan, thank you. So you get a moment to pause there, Paul, and think about that. Right, so we're sticking with Parks and Leisure. Leslie, are you on Parks and Leisure?
Yes, so I just wanted to ask, because I understand the Labour government have set up a playground fund that's worth £18 million, and it's for supporting refurbishment and creation of children's play parks, but it's for targeted areas. So does Baines have access to this funding? Does anybody know? We applied for it?
Paul, you might be the best place to answer that.
Yeah, I'm sorry, I don't know the answer, and I'll sound ignorant, but it is because Parks is just in another directorate, so I'm really sorry. We're very happy to find out. We may be accessing it, or we may be looking to access it, so I can try and find out the answer from the appropriate person.
No, that would be brilliant, because
Yeah.
I think I was asked recently to go and look at some goalposts being literally moved in one of our play parks, but I couldn't go because it was the same date as our last meeting. And I'm just wondering if perhaps we got access to that funding, but if not, maybe we should see if we can tap into it.
Okay, that's a very good suggestion, Leslie. Michael and then Liz.
Yeah, you mentioned in here about 55 play areas across 179 parks and open spaces, and I was just wondering where in Baines where the locations are and in what wards, because as a local councillor it'd be good for me to know what those parks are, and we have obviously green spaces in that may not be council run, maybe run by other people, and just getting a better idea of where they are and what condition they're in and how well they're used. Yeah.
What I'll also do is I'll pick this up in our joint chairs meeting as well, because I think there's elements here that are definitely cross-cutting across corporate as well as our panel and public health.
I believe there are quite good maps and assessments done, so that information may well be available, and it does look at availability in areas across Baines. It looks at some of the quality of places, and I think that's really useful information. It's not been presented in that update, but I think probably some of that is already available, but it could be contained in a future update.
So I was just being given an update on the funding that I think Leslie was talking about, and I think there's 270,000 that's been allocated to 66 councils. We're not one of those, but were given the £20 million Pride in Place fund, which in theory is a sort of like a parallel funding stream, could address some of that need. But anyway, I think we'll need a deeper discussion on that in due course. But that's more for Paul and Leslie's benefit. Sorry, Paul, you were about to answer, or Alison was going to answer Michael's question?
Yeah, I think I did, but just in terms of, I think there is good assessment and mapping done. I'm not directly involved in that work, so I'm not going to sort of commit other officers to that, but I believe there is good mapping and that could be brought, and it will be informing those plans and things. So some of that and the issue about gaps and things, I'm sure will be part of something like that.
Okay, and as I said, we can pick this up in the as a cross-cutting issue as well. I've completely lost track of who was going to be next. It's going to be Liz. Because she says so.
Thank you. It seems to be very Bath-centric, this, and looking at enabling play, and there was a green motion about this, enabling play as well. So looking at play parks, which are going to get investment in the next 12 months, how many are in Bath? How many are outside of Bath? Do we know which wards they're in? Obviously, I'm speaking from my ward of Poulton, but there are many of us outside of Bath who would be interested in this. And what work is planned for those not inclined to use what's there? Or how are we encouraging and supporting people to use these play parks when they get this investment? Thanks.
I mean, there has been quite a lot of investment in play parks over the last few years, as was discussed when the motion was debated. I think there is a different landscape in Bath City compared with the North East Somerset, because often in North East Somerset it's the parish councils that are responsible for the play parks. So I think that needs to be borne in mind, that investment by the council may be more in Bath parks because the investment in North East Somerset comes from another route. And I think that's part of the detail that will need to be looked at in developing the policy. In relation to how you encourage people to use parks, I mean, I think if you create a nice space, then people will generally go there. And certainly in my ward, there's been quite a lot of investment in a couple of parks over the last few years, and you certainly notice a lot more children making use of them because they really are very nice facilities now, whereas they were a bit run down before.
Thank you, Alison. It does seem a little bit unfair that we're relying on parish councils outside of Bath to fund our green spaces. Thank you.
I don't think you need to comment on that, Alison. Right, so who has any other questions about parks? Anybody who's not spoken already? So I'm going to take... Kevin, did you put your hand up some time ago to talk about parks or not?
I did with the question about the
That's
distribution.
Fine. If it's already been done, that's good. Joanna.
Just pick up the point that I know that Curo owns an awful lot of green spaces and play areas that are not well maintained, and how would the council be working with those kind of providers?
Okay, I think that's a point that is well made. Okay. Right, so we now move on to any other parts of the report that people want to ask questions about. I'm going to see who hasn't spoken. I'm going with Michael. I know he has spoken, but not as much as others.
Yes, a couple of points on the rest of the report. A bit on the direct payments project. I know obviously that the new direct payments lead's been doing a lot of work in putting that policy together now. And I know that there was a lady, Suzanne, I think her name is, who was doing the work before Gemma took on that role. And obviously there's a lot of work that she had done, but it sounds like, looking at the review, inefficiencies and inconsistencies in systems and policy processes. So I'm just interested in knowing what were the issues that were raised the first time around that haven't been picked up or are now being picked up by Gemma's role. And then also we mentioned the aim to have an all-age direct payment project And I'm just wondering what's the kind of timetable we're looking at in order to get direct payments up and running in the way that we'd all like them. Because I appreciate that Baines is quite low down in terms of local authority take up on direct payments, but it's something that I know will make a big difference to a lot of people. Okay.
Thank you, Councillor. Suzanne Westhead, I'm the Director of Adult Social Care for Bath and North East Somerset Council. You are right, there are inefficiencies and there is not enough support. Actually, we don't have enough resources in the community to develop more personal assistance, and that is the whole idea. And we want to standardise as well the payment to personal assistance. So there is a paper due to go through to Cabinet in autumn this year to actually standardise the payments for direct payments, and also make sure we do, as you said, an all-age approach to direct payments. We have at the moment 8.6% people on direct payments, which is about 300-400 people. Nationally, it hasn't really been taken up well, so we're developing our infrastructure to be able to have more personal assistance, more resources for people, and a fairness across the payment schedules for personal assistance as well. So we expect that from a child point of view up into an older person point of view, right through to working age adults. So that's the process we're working through, but we will need to consult with people, and that's what we're asking Cabinet to agree.
Is it on this same subject area? Okay. Any other questions on this area? About direct payments?
Thanks. There hasn't been a review since 2019, Suzanne, so why was this? And secondly, a huge amount of work needs to be done on it, doesn't it? For example, lots of inefficiencies and inconsistencies were highlighted in the report. So I'm pointing that out, and you've been very honest about it, but could we have a report on delivering an improvement to this panel? Because I think that is really quite important. So it's not a question, it's just a request. Yeah.
Yes, happy to do that. It's one of our priorities, one of our 9 priorities for this year.
Thank you. Joanna? Any other questions about direct payments? Okay. Right, now, other questions about other items, Joanna?
First of all, I have 2 suggestions for press releases. We are, as you all know, in a heat wave. We had a press release last year about cool places. Can we have another press release on that? I think that's quite important. We're also in the midst of a 5-week World Cup football matches of where we know domestic abuse is increased, particularly around football time. Can we have something about that to support the people who are impacted by domestic abuse, which is a serious issue? Then the question on the CQC assessment, when this will be completed and the outcome shared, can you give us a bit more of an update on that issue first, please?
So CQC, this is their first, we're the first council to be inspected under the new framework. So there's 153 councils and we're the first one. So that will mean it'll be a quite serious position for CQC as well, because we will see the ex-president of ADAS come on the day of the inspection, and we'll also see the chief inspector come, because as I say, it's the first in the country. So we're very lucky to have that opportunity. That means that previously, when CQC, we were waiting for a report from CQC, it would take maybe 3, 4, 5, 6 months. They're now saying that it will take from the date when they told us we would be inspected, which was in May, that they will have the report done by October and be published by October. So what I'll get on the 10th of August after the inspection, they'll give me a sort of an update of where they think we are. I won't be able to understand what that rating will look like, but I'll get the feedback, and then they'll give me a first draft sometime in September, and then be published by October if they keep their framework. I think they will, because it's the first one. They've picked one other council in London, Hammersmith and Fulham, and I've just heard now they've picked another 4 for later on in the year. yeah, so interesting times.
And then just picking up on the holiday activity food programme.
Can I just check if anybody else has any other questions on the CQC? So CQC, Leslie, and then David.
Yes, on the CQC, I mean, it's surprisingly early that we're being expected to respond to this, and I expect there's quite a bit of work going on behind the scenes, as there always is. And I note, Suzanne, your response of how exciting it is to be chosen first. I'm sure it is. But I'm just a bit concerned. I'm sure that you'll meet the deadlines, but what mitigations are in place to make sure that what's being delivered is accurately reflected and it's not just on paper and ticking boxes and things? Thank you.
I think that's a very good point. I've been out with all of the services over the last 3 months, just making sure what we said we did do was actually we were doing. We've reported the scrutiny as well. I think on 3 occasions I reported to the corporate management team as well, and on top of that it had went to cabinet 2 months ago as an update. So there, I also have a quality assurance board which looks at all the activity. So for a good example of that would be waiting times for Care Act assessments have significantly gone down. When we were last inspected, when the service had just come back 4 days beforehand, waiting times were quite high. They were over 200. Today, a Care Act assessment is 68 people are waiting for a Care Act assessment. Reviews were at 50%. Today, reviews are 73%. So I can see the evidence, the practice and the improvement in practice, the feedback we get from people, which is the most important thing. That feedback has been good. There's always more to do. So we've been training people within Swallow, which is one of our organisations, our voluntary or charitable organisations. They've been out talking to people. We've had other areas where we've had feedback from people about their experience of assessment as well. So we're constantly triangulating and seeing. I do audits myself, my team do audits. So it has to be more than just what's on paper. It's actually the outcomes people feel. And we look at the regular surveys we have as well and how we improve in those. But if I look at the benchmarking nationally, if I benchmark it up against some other areas, I can see the constant improvement. So yeah, there's lots of ways of triangulating. I'm sure I've missed some.
Thank you for that, Suzanne. You did say before how the figures had gone down, and it is an achievement, and I think, you know, we do need to note it. And I think also it's a good example of Anchor Institution working, that we're working with organisations that receive the service and getting their feedback, and hopefully that's going into the future design of services too. Thank you.
Thank you. So it's actually really good to draw that positive element out as well. Any others on CQC? Michael, I think you had... Not on the... Okay, right. Another item in the report, Michael, we'll go with again.
The damp mould and cold homes, I was interested in understanding a little bit more about what the toolkit was that was aiming to be produced for residents to access advice and support, just to understand a bit how we can keep our residents informed of what they can be doing if there are issues about cold and damp and what they can do in their homes about it. Because obviously we have a lot of Curo properties where there's issues as well, and does that involve Curo properties, or is it just Baines run properties?
Yeah, thanks. I can say something about that. And actually, I think Curo housing generally is pretty good around keeping good ventilation, energy efficiency, and so on. So it's probably the biggest risk is in our private rented sector housing with private landlords. And the toolkit gives practical advice. You can download it from the website if you want to have a look at it. So it's on the council's website. It gives information about how to improve ventilation in the house, how to keep a regular temperature. There'll be information for people on a low income about how they can get support around keeping homes warm. about things like keeping washing in the house, how to avoid creating lots of moisture, so and what to do if you do have problems with damp and mould, and how to work with your landlord if you've got issues that you think need to be addressed, so especially if you're in private rented sector housing. So it's those kind of really practical advice. It's all just downloadable, or you can just read it on the website.
Those that don't use the internet but maybe suffering from those issues, how would they find out information about that there is a toolkit and actually what that is and going to help them on a day-to-day basis?
So I think we do work with, there are private sector landlord forums, and there's obviously our social housing providers, our registered providers. So the team have worked very close to our public health team, have worked very closely with the council's housing team to work with those forums for those landlords. So they should be acting in their kind of responsibilities and be aware of that as well. So we're trying to create an environment where people are acting proactively about it. It's a good question. I'm sure if people did contact the council's kind of Council Connect line, they would be informed about it. But it's a good question that I'm happy to take away just to check how we're making sure it's accessible for people who aren't using phones and computers to access them.
Yeah, 'cause we did a little exercise on Friday to look under damp on the Baines website and nothing came up. So if the Baines website is a main source of information for people, it's actually not working at the first stage.
It wasn't working.
So I don't know whether we need to look at that as something around the Libwell Baines or those sort of other forums, as whether there's more we could be doing to get this information out there.
Okay, thanks.
Actually, just picking up on that point, it'd be really helpful, I think, if all the different partners' websites all pointed to the same sort of sources of information as well. I think that's probably slightly outside of your remit, Paul, but if you could just take away and sort that as well, that'd be great. Thank you. David.
Thank you, Chair. It's a follow-up question to Paul, really. How do residents access these forums if they've got an issue that isn't being met by the housing association or the landlord?
I have to say I don't really know, because housing, again, lies in another directorate. I could find out that answer. I think the forums are more for the council to work with those groups of providers of housing to try and improve standards, to try and work together on those sorts of issues. I think, if I'm understanding you right, if a resident had an issue and wanted to raise it, I would have to ask housing colleagues what the best route is to do that.
Alison may know the answer for this, but I certainly have a number of residents who have raised this with housing associations and seem to have got nowhere.
I can just give examples as a ward councillor where people have approached me with concerns about damp and mould, and I've either directed it to the housing association, or if they're not in a housing association home, I've directed it to Baines Housing Services, who have said that they would follow up. So those are the couple of routes that I've used, and with some success they have got an appropriate outcome from it.
Thank you, Alison. I guess I haven't had as much success with a particular housing association, so I was just wondering what route there was. But perhaps we can take this outside.
I think we could definitely take that up as an issue, but outside of this this forum. And just to add to another body that can help, probably not in your area though, David, which is the Student Community Partnership, because if you're a student living in a house that has mould or whatever, then that is another route that you could take this issue up with. Sorry, Paul, did you want to come in?
I was just going to say, I just put damp into our website, and the first thing that comes up is the damp cold homes toolkit. So, but I take your point that for people who aren't using the internet, it's we need to think of that as well.
And if perhaps you put in not damp but mould or something else, maybe a different answer might come up. Leslie.
Would it be worth inviting somebody to come and talk about that toolkit at this PDS?
Yes.
People find it useful?
I think so. Can you take that on Thank you, Paul. Yes, and we'll schedule that into our agenda setting as we find the right person to speak. Okay, so damp and mould, Liz.
I don't know if I've missed this, but apparently there's a very good toolkit on damp, mould, cold homes, which when you're bringing information to this panel, maybe you could bring that as well. But my question is about the dementia strategy, which has been updated, and it's good to see that.
Sorry, I don't think we finished with damp and mould yet, Liz.
Oh, sorry, excuse me, I thought we had. So
let me just check. Have we finished with damp and mould? Are there any more questions on this? Okay, now we can move on.
Okay. So is it okay to move on to the dementia strategy? I know we're jumping back a bit. Thank you.
We can.
And it's good to see that it has been updated, but we need a definite date as to when it's going to come to our PDS panel. So maybe, Suzanne, if that's possible, that we do have a definite date. Firstly, when do you think it will be published and ready to bring to our panel? And I am assuming there are forecasts of need. And do we know what they are? Do you know what they are at the moment? And will the strategy include integration of dementia need into all parts of service planning? Thanks.
Yes to both those questions. It will be looking at forecasting and the number of people in Baines who are likely to have dementia over the next 5 to 8 years. So that will be there. The time frame depends on the amount of co-production we do, to be honest with you. We want to get out there and in particularly talk to carers and the Carers Centre and the work that they're doing there. And we've had a number of people who have dementia who've been talking about what they would expect to see across the community, not just adult social care. And there's already a dementia strategy in health through the ICB, and we're connecting in with that as well. But it isn't a refresh of a dementia strategy. This is a new strategy which came directly out of this panel, if you remember.
Thank you. Any more on dementia? Any other questions on any other parts of the paper? I'm going to take Leslie, then Joanna, and then Liz.
Yes, so the staff survey results are now out for the NHS. And I've had a skim through, and some of the ones for the IUH are a bit worrying. So, for example, there's only 43% of staff don't think about leaving, which is exceedingly high. Only 29% of staff think there's adequate staffing. And although they're saying that turnover is low, sickness and dissatisfaction rates are very high again. So can we ask for a report on the improvement actions being taken to tackle that staff health and well-being? Thank you.
Alison, did you want to comment on that question?
I don't think that was included in my report. So I'm not quite sure how to respond.
CICB report.
CICB report, I think.
I think yes, it sounds like it's on a different paper.
No, it was reported at the last IUH meeting, but the staff survey results, they came out beginning of April. And I've had a look at them, so I'm saying, can we ask a question around that, what improvement actions they're taking on it?
Okay, Caroline, do you want to try and pick that up when it comes to the ICB report? Thank you. Right, other questions on Alison's report? Joanna and then Liz.
Thank you. Mine is to do with the holiday activity food programme. It's good to see that this is on the list and things are moving forward. Could you tell me, first of all, how are you ramping up HAF to another 4,700 places for next summer, 2027? Are there any wards which don't have the HAF option? And do you have any base data for this summer of who's using it and how, and particularly with children who have SEND provision?
This might be more for Paul, I suspect.
So children eligible can apply for credits, and then they can use those activities across the districts, as I'm sure you know. In terms of kind of data showing where people are using them and what uptake is like and so on, we could explore that and look to find that. It's, as the report says, it's being brought into the council, so to be operated by the council. It'll actually link into children's services, I believe, and so we'll be able to have kind of good information about it. We could come back with where people accessed in the previous year, so last summer, if that's helpful, but there is provision across the area, and people can choose which activities they would like their children to be able to go to, if that answers your question.
Perhaps we'll have sorry, I was just going to say, I think what we need is some update in Paul May's report at the next meeting, which will be in July, and then we can explore that in more depth at that point, okay?
We certainly need baseline data, but I would also add that, not everybody can easily access that kind of facility. So it would be useful to know where that is and how easy it is for people to access, and are they using it well? Thank you.
Thank you. Any questions about HAF?
Yes, I've been a really big supporter of HAF. They come out to Poulton and other places around our area. But what were the deciding factors that led to the decision to bring it in-house? Because I thought it was quite, well, I'm delighted it's in-house, but I thought it was quite a successful enterprise.
I'm not entirely sure of the reasons, but I believe it will be around the opportunities for kind of integration with our wider work around best start in life and children's services and things and so on. I can give you a more specific, I can get you a more specific answer around that rationale. So sorry, I haven't got that.
Again, I think that might be a question that would be more relevant to Paul May to answer, because I think there will be a political element to that as well. So we'll ask for that in his report, which comes to our next meeting. Any more questions about HAF? Right. Any other questions on the paper? Okay, I had a couple of questions which were around autism and mental health, and I wondered whether the lessons that we've been learning from the work with Swallow, particularly around learning disabilities, autism and neurodiversity, whether or not there was learning that could be taken more wider, and whether or not, because you might recall at the last meeting I did ask for a piece of work to be considered around our autism strategy, and I just wondered if any of the learning from that would be being fed into that piece of work, into any future strategy.
It's the same commissioner working on both, so yeah, the expectation will be that the work will come back here. The autism strategy will come back here as well. We're in the process of doing demand modelling at the moment, and then to see how, in the same way that we've done the other strategies. So yeah.
Thank you. And then my final point, which I think probably is more for Jean Kelly and for Paul, which is around mental health and other programs, programs such as the Best Start in Life and Family First and the Mental Health Summit, etc., and just to check that they're all being worked together and they're not all being dealt with as entirely separate strands. And also, if that work on autism is being fed into the, that development of Family First and Best Start too.
Because we've got an all-age commissioning hub and the strategies are developed there, and there's leads for each of the areas from start well, live well and age well. So the expectation will be, Jean and I will work very closely together to make sure that these strategies work across families rather than core groups of people.
So therefore, just going back to an earlier point that I think David made, which was if I wanted some advice on, autism support, I could just put in autism support and I would be led to the right information regardless of who was providing it or who was being commissioned to deliver. Okay. always someone who wants to have the last word, isn't there?
I know, sorry about
Liz.
this. New bus routes have been published, and I just wondered, have you been consulted on the health and well-being? If you have, it would be good to hear about it, but perhaps next time round you could bring us in your report, you could comment on it.
Is that to Alison or to Paul Scott, maybe?
Yeah. I would have thought Alison, but I'll pass to Paul Scott.
Alison, do you have any comment to make about buses?
I suppose the only thing that well, obviously having more buses is great because when people are isolated, it has a really negative impact on their mental health and well-being. So I'm delighted that the bus provision does appear to be improving. One thing that came up with the last heat wave with one of my residents was they raised the issue about the temperature on buses and what can be done to ensure that people are not in very crowded buses in extreme heat and really feeling the impacts of that. And I did pass that on to the colleague who leads on buses who was going to raise it at the bus forum. So that's one example that's quite pertinent to where we are today as well.
Okay, and you might be interested to know that tomorrow there is a WECA-led briefing on changes to the supported bus services. I think that's on Teams in the evening, 6. Okay. I'm just picking up on that, though, Alison. Do you think the bus strategy, bearing in mind its the impact on mental health, isolation, etc., is this something that could be being discussed and should be being discussed, perhaps at the Health and Wellbeing Board? Because you've got a range of sort of partners, including the universities, and I don't know if First naturally would come to that, but maybe they could.
Yeah, we could, I mean, it could be something like a development session, could be an opportunity to look at something like that. There is proactive work that happens with the council's travel and place shaping teams to look at things like access in different parts of the district and its impact it has on things like loneliness or food or mental health and things like that and access services. So there's lots of proactive work. I don't know in relation to specific changes whether there's a kind of impact assessment around that. But it could, in terms of looking at the health and wellbeing impacts of travel, could come to a development session. That might be the right kind of space, or it could, which would have a really good multi-agency chance, or it could be that it comes as an item. But we could take that to an agenda-setting meeting of the Health and Wellbeing Board to discuss, if that's helpful.
Thank you. Very happy to help set an agenda there too. Alison.
Can I just add, it has come up under the Ageing Well umbrella, the work that's been done on that. And the need for people to have access to buses in order to be able to stop being isolated. And I know some work has been done with the bus operators on training for staff to enable them to work better with older people. So I think there is some work going on, but yes, it might be helpful to have a focus on it.
And just as a point of information, the bus strategy is going to the WECA Transport Board or to the Joint Committee in October of this year as well. And obviously it will be scrutinised through WECA, the WECA Scrutiny panel there. But I don't know if they would pick up the health elements that we've been interested in. So I would very much welcome the Health and Wellbeing Board's look at this issue. So thank you, Paul. Joanna.
I'm just going to pick this up because I know that at least half of the numbers of people attending the RUH actually come from Wiltshire. With the recent street works that have taken place in Manvers Street and outside of the Guildhall, the buses that you have to collect to get to the RUH require you to get off at the Hilton, walk all the way to the bus station and change buses there, and equally do that bus journey back. No information was put up at the bus stations about that or put up at the RUH on that. And I do think there actually needs to be a multi-agency approach to how we approach street works across the city when they fundamentally impact bus services that get people to the RUH who were invariably distressed by what has taken place. I know I had lots of contact from a whole group of people that had just been to the RUH, were told nothing, ended up at the bus station, and on one of the hottest days in May had to make that journey and were feeble and unable to, and nothing was told to them. So we need a better system.
I'm not sure this is exactly the right forum to talk about buses to the RUH, but I have my own issues and questions around buses to the RUH as well. We will find out perhaps the appropriate channel to put that commentary into. Right, any more questions? I feel like I need a gavel really to say, any more questions for the Cabinet member? No? Okay, so we move on then to our next item. I think, Joanna, you wanted to leave for a moment, didn't you? So we have the ICB's report, which we will have had before us. I wanted to say thank you. It's to Lucy, not to you, Caroline, but thank you for attending anyway, for, I think, the very tidy way it was all put forward, the fact that questions are clearly laid out, questions that have been asked, and I in this instance, I like the way that it was focusing on one particular subject. So if you could pass on that, my thanks to her for outlining things so clearly there. Is there any questions that anybody has either on this item or anything they'd like to see on a future ICB report? David, and then Kevin, and then Leslie.
Thank you, Chair. It's regarding dentistry. We were previously told that there was a plan for being developed to how to collate and obtain information on the rural need for dentistry and a dental bus, given the potential for the dental desert that residents are suffering. So I'd really like to know how that is progressing and what specific measures are being put in place in the rural areas to get that information for residents. Obviously, I don't expect you to have that today.
Did you want to come back on that, Caroline?
Yeah, no, absolutely. I'll take that away and talk to our team internally within the ICB. We do have a range of measures in place to support high risk and hard to reach communities, but I'll just make sure that I've got the details that you're asking for there, and we'll include that next time.
Okay, yeah. Kevin, and then Leslie, and then Michael.
Thank you, Chair. I've got a few questions, but can I stick with dentistry to start with, if that's okay?
Stick with dentistry, because that seems to be the main focus of this report, and then if there's other items you want to bring up after everyone else has spoken about dentistry.
Okay, thank you. So on dentistry, 3 questions really. The first one was that very kindly Lucy was trying to answer the question about my repurposing of the surplus as to where it's gone. I'm afraid I was a little lost after reading her bit about the background and the summary of spend, which didn't seem to tell me in a nutshell, and maybe it's my naivety here, to say we've got 210,000 left over and that money was here, went to there. That's all I was trying to get at, and maybe I didn't explain myself too well. So if that could be picked up, that would be fantastic. The second item around dentistry was the it was mentioned about stabilisation of urgent care, starting in COVID times, but maybe it's still going on. And the question really was, is this still an issue? And if it is, how is stabilisation being maintained? And finally, around dentistry, supervised brushing. How successful is the scheme and when is it being evaluated? And when will all communities have sufficient access to the NHS dentistry to enable things like these additional programmes and emergency programmes not to happen?
And I think that last question is probably the most fundamental one of them all, really, isn't it? Because it's about the access to NHS dentistry overall and what our plans are to try and widen that access. I'll talk about it in a minute, but you'll see that stabilisation is still quite a key programme and an issue that we still are addressing at the moment. So it definitely continues, and it continues to be funded as well. But I can talk a little bit about that as I go through the dental update.
Thank you. Other questions directly on the paper? Okay, anybody else want to talk about dentistry? Right, anything else that ICB does that isn't dentistry? Liz?
Neighbourhood plan. The neighbourhood health plans will be submitted to the Health and Wellbeing Boards for approval, I believe, fairly soon. Firstly, why are you calling an area in North East Somerset the Three Valleys? Because I live in one of those valleys, and most people where I live haven't ever heard of them. So I know they must be the Cam and Somer and somewhere else, but not sure. We're normally known as the Chew. Sorry, excuse me. And I, you know, my geography is failing me. So could we have Somer Valley or something which residents are more familiar with? Secondly, we're not getting very much from the pot of money, and Baines is only getting £276,000 from a 1.5 million across the BSM. So could you explain why that is? I have another question on the Better Care Fund, but I'll just leave this with Neighbourhood Health now.
Okay, Caroline?
Yeah, thank you. I'll take away the request for the Three Valleys naming and take that back into the team. Obviously, the neighbourhood team areas, those footprints that are described in the paper, have been developed with our local GPs as well, and the relationship with GPs is very important. Also with HCRG, our community provider, and also our local authority partners as well, and the ICA, the Integrated Care Alliance. But on the specific point about will people recognise the name, I'll take that back and make that point very clearly. In terms of the neighbourhood health programme, that's set out very briefly in this paper, and we can certainly bring back more detail on that if that's helpful. That's a programme that will support all of the neighbourhood health teams across Baines, Swindon and Wiltshire, and it's a programme that will help those teams to spend time getting to know each other, developing a plan for their priority communities and populations, and putting that plan into action. So it's a programme that also provides some backfill funding for local GPs to take part, and also for VCSFE sector partners to take part as well, because we recognise that it's quite difficult for them to be able to have the time to take part, whereas for statutory organisations and others, it's more built into their time. And that programme lasts for the rest of this financial year, and we hope we'll move into next financial year, at which point those teams will be functioning well, people know each other well, and will be able to work together effectively. In terms of how the funding has been divided out, that's based on the number of teams in the patch and also the population size as well. But there is also some funding within that is covers the programme costs, if you like, so the facilitation of the work, and also the support for GPs and third sector colleagues to take part.
David, and then Michael, and then Kevin.
Point of information, really. The Three Valleys is a primary healthcare network in Somerset, covers tube medical practice, for instance, Summer Valley Medical Centre, Westfield, etc. So that's probably why they've used the name. So.
Thank you. Is there another question you wanted to raise, David? Or
No,
can you
thank
turn
you.
your microphone off then? Michael.
Yeah, I was interested in the health workshops that were done, and actually I know there's a second one coming up. And I was just wondering, firstly, whether there was a chance for us to get any kind of summary or feedback from what came out of that workshop, but also whether there was scope for anyone from this panel to be actually involved with that workshop, whether a member of Scrutiny should actually be present at the workshop, because you'll learn an awful lot about some of the practical issues that some of the members and groups that are represented there are, and I don't know if anyone else had any thoughts on that, and I'd certainly be happy to attend on behalf of the panel if that was appropriate or not. Yeah.
Thank you. So as you can see in the paper, there are 3 workshops that are being planned. One of them has already taken place at the end of April, and that one really helped us just to work together across for Baines, for Swindon and for Wiltshire, to start to really put some detail around the vision for Baines and the priorities for Baines as well. The next workshop is focusing on neighbourhood teams, those footprints, and how those teams will start to work together. And the last workshop will focus on the remaining elements of the neighbourhood plan that we need to develop together. So the workshops have a wide range of colleagues attending those, so they include local authority partners, so Suzanne and Paul and other colleagues have been involved and invited, and it also includes other partners such as our community partners and BCSFE groups, and also our primary care colleagues. So we have a wide range of people attending, and I'll certainly take back the suggestion about the membership back into colleagues who are organising the event so that we can consider that. So thank you for the offer.
Thank you. Kevin?
Thank you, Chair. Yeah, 3 questions. The first one is, just wondered how, at the moment, the thinking is behind the neighbourhood health teams delivering the preventative care. So what actually are they going to be doing to enable that to happen? The second question was, on what basis were the 3 neighbourhood areas selected? Was it just historical, geographical, or was it designed to cover particular populations in a particular way? Because that links also to the funding, because if we knew what the criteria was on which it was selected, maybe we could argue with you that Poulton doesn't have enough targeted funding, or whatever it might be, because they have X and the others don't. And finally, do the community health neighbourhood teams, which seem to be run by HRCG, and these integrated neighbourhoods, do they work together? Are they part of the same footprint, or are they not quite aligned yet?
Thank you for that. So just in terms of neighbourhood teams going forward, so they absolutely will be wanting to address prevention as well as targeting most high priority groups to start with. So the neighbourhood health guidance does ask that we focus on high priority population groups to start with. So for example, those at high risk of hospital admission or at high risk of developing a number of conditions that mean they may call ambulances more frequently because their condition is at risk, or they're unable to maintain their health at home in the community. So those groups are nationally priority groups, if you like, but across Baines and Swindon and Wiltshire, the aim is to work much more broadly than that, and to make sure that we are not just writing a health neighbourhood plan, but that it involves partners and really thinks about local communities and how those communities can work together in terms of helping people to maintain good health, but also to recognise that there are so many agencies who work on a day-to-day basis supporting people, and it's not just about the urgent end of healthcare that we're trying to deliver. In terms of the HCRG integrated teams, so they have organised themselves across a range of footprints, and that's the kind of the starter towards the wider integrated neighbourhood teams. HCRG have worked very closely with primary care colleagues to propose those sort of final 3 footprints that you can see, but operationally and underneath that there will be a lot more work that will happen going forwards on how they work together on a day-to-day basis, and also that neighbourhood health programme that's referenced in the paper, that's just one-off funding, so I just wanted to reassure colleagues that it's not an ongoing resource that goes into those teams. It's about one-off funding to support them to build those relationships, really understand what each other does on a day-to-day basis in the community, and support them to begin to identify how they will work together, the people that they want to provide services for on a day-to-day basis, and really have that support from an integrated team which will include a number of different partners. So that funding is not an ongoing pot of money, it's a one-off pot of money for this financial year that will support those teams to get to know each other, develop a plan, identify the people that they want to work with, that they feel they can support most effectively, and support those people to remain well in the community, and they will develop a plan amongst themselves that will then unlock further tranches of that funding and help them to implement that plan over the next few months. So it's in quite early stages, some of that development, and at the moment they're just going through the process of appointing and a facilitating organisation who will support them to run that programme over the next few months.
Leslie?
Yes, that all sounds really interesting. Is there going to be work with different communities around this so that they can contribute to this plan? And can we have a look at it at some point so we can see how well it's working?
Is that possible? Yes.
Yes, and absolutely local communities will be part of the development of the wider neighbourhood plan for Bath and North East Somerset, but also the elements that focus on those 3 areas as well, the 3 core footprints. So there will definitely be engagement planned, and I'm sure we can bring an update on that, or I'll ask Lucy to include that next time in her report.
Thank you. Right, I think I've got 2 more speakers. So Kevin, I think, wants another question, and David, it turns out, and Liz.
Thank you, Chair. I was actually going to ask the same thing as Leslie did about actually seeing the plan, and then we could review how, if particular areas have particular needs, how that funding may be coming through and what it's doing. Thank you.
Thank you, Kevin. David?
It's sort of related to changing community provision, but it's related to the local plan in terms of development across Spain's rather than your neighbourhood plan. Confusing names. So I really want to know, and it may be better to come back with this again, but how are the ICB feeding into the local plan with various potentially large developments planned that will affect GP-based provision.
Yeah, so I can answer it very briefly, and then we can definitely bring more detail back to you for next time. But every time plans are proposed around either large housing developments or significant changes, those are shared with the ICB so that we are able to comment and feed back on the potential impact for health services in the area, and also able to offer advice on that as well. And that also enables us to work with those developers and in terms of those proposals to ensure that there is health provision included where that's appropriate. But I can bring a more informed response next time if that's helpful.
David.
Yes, if I could just follow up. I mean, so to some extent it's not about buildings, it's about staff. So I would like the answer to cover that if possible.
Okay. And actually just picking up on the sort of general thrust of that point, it would be interesting to know whether or not you're going to, the ICB's views are going to be taken into account as that overarching plan is being developed, because, you know, I think it's right that you're being asked on individual planning applications, but I think in order to ensure that the strategy is in place, which will also pick up about staffing as well, the ICB should be being involved at the earliest possible stage, which would be as the local plan is being developed.
Lucy and I haven't spoken about this in great detail, but I do believe she is involved, so we can just double check that as part of the information next time, but I do believe she is involved.
Paul.
Thank you, Chair. Caroline might not have been aware, just from not being Lucy, but there was a presentation to the Health and Wellbeing Board just a few months ago on considering health infrastructure, staff, locations, pretty more locational, and working with a neighboured plan. So that was with Richard Deo, our deputy head of our kind of place shaping services. So there is a presentation on that which might have some useful information. And a few months ago I could find out exactly which Health and Wellbeing Board it was. It was probably 2 or 3 boards ago, which might be useful.
And actually, just as a follow-up then, is there a similar process? Because obviously I think WECA sort of combines the local plans together. So is there a similar process of involvement at WECA level too?
There is. So there's a spatial development strategy group. I attended that at the last one and lobbied and raised for the importance of including health and well-being, which includes health infrastructure, health services infrastructure, as a key objective in their spatial development strategy for the West of England area. So there is close working, but sometimes the focus is more on economy, travel, housing, and it's keeping that importance of kind of health and well-being and health service infrastructure in there as well. But there is absolutely involvement in that.
But not staffing.
Well, it's a really important question, isn't it? And I think that's probably a slightly different kind of route. But it's a really important question, isn't it? But buildings are only as useful as having staff working.
So buildings are slightly pointless without the people to work in them.
Yes, and obviously workforce development is a critical part of the NHS 10-year plan and also the ICB's operating plans going forwards. It's something that we are very aware of. Well, nationally it's a huge priority, but also locally it's built into our organisations, our sort of provider plans as well. There's an expectation of development of workforce going forwards, and how those organisations also work together to enable staff to work between organisations, for example, but also to encourage the take-up of a wider pool of people coming into the NHS and local services. So we do expect not only for ourselves as strategic planners, if you like, but also our providers to have their individual plans for sustainable workforce.
Liz, I think you might be the last speaker.
I'm not speaking. I'm
not speaking.
I'm not speaking. Sorry, not speaking on what's been discussed at the moment. I'm looking to talk about the Better Care Fund.
Okay. Is there any other questions on the point that we're currently on? Otherwise, I will allow Liz to change the subject matter and we'll talk about the Better Care Fund. Right, off we go.
Thank you. I've got 30 seconds or so. The Better Care Fund is a huge budget, and in Baines it covers 26.5 million of jointly commissioned services. I'm reading from the information we've been given, 2026-27. So a plan, the delivery plan for 2026-27 was submitted on the 19th of May 2026. Would it be possible for us to have oversight of this at our next panel meeting?
I lead for the Better Care Fund, and we report back to the Health and Wellbeing Board quarterly. We're quite happy to bring it here as well. I suppose what I would say about the Better Care Fund, it is the fund that we use. We pool our resources together to really, a lot of that money is going through the voluntary sector, the voluntary and faith sector. It really helps us around some of our delayed discharges. So people who are in hospital, making sure they come out appropriately, they're well supported. And the Department of Health and Social Care at the moment are reviewing next year's allocation and what the Better Care Fund will be used for. So we're waiting patiently. And of course, the voluntary sector in particular are very concerned about that, because what does that mean for Baines in the future? So it's a good time to bring it in. And I've made the Health and Wellbeing Board aware of that, because both myself and Lucy have the responsibility, you know, for the funding and the agreement, and it's been quite stable, and it's really made a difference to the community. So it's an area of concern for us, because I don't know how much is going to change. There is a real focus at the moment around neighbourhood health, and is that the way to use it? But of course, we've really tied ours up in areas that make is an impactful for our residents. So I am quite worried about it. So it's a good time to bring it in.
Any other questions about the Better Care Fund? Kevin? Okay. Any other questions on the Better Care Fund? Otherwise, we'll move to whatever subject Kevin wants to talk about. This is on the ICB report.
Still ICB, yes, please. Yes, thank you, Chair. It was really around the first part of the report, around the pharmacies and shops. It was sort of when I read it, it sort of just seemed to say, because there was no, at the moment, the pharmacies aren't paid to collect patient shots nor equipped, and that was it. But there didn't seem to be any idea given that there was a consideration and a deliberation around the benefits that were being suggested by Councillor Jackson, in terms of, well, if you're running around collecting everything door by door and it's not coming to a single point, that surely is climate impacts, etc., etc. So was it actually considered, and if it was, can we actually understand what the discussion was for the benefits and the downside, and why it's staying the same?
So thank you for that. I think when we looked into this issue and unpicked it a little bit further, it became clear that the collection of sharps is something that is coordinated through the local authority. So it's coordinated through the waste team. Paul and I were having some conversations just before the meeting, though, about some other related concerns that have been raised around patients having sharps collected, and I know there is some work happening across the ICB and into the local authority to look at those considerations. But I guess your wider point about the strategy around the collection of sharps is not something that the ICB commissions. It's led through the waste team in the local authority.
Just so, how would that? So you don't have an input or report back from them, or an input into how that can be done effectively? Because it just seemed to now pharmacists are taking on a greater role. If you, as you know, in all healthcare, it just seemed from one angle a logical progression and a sensible one that the health waste team go to one point in a community rather than 16, maybe. So I just wondered how that was not sort of both overall an efficient use of resources and a sensible way of actually supporting the people who had raised the concerns about being collected in the first place.
Yeah, so I can certainly take that back and pick that up with the waste team here in the local authority, and just to make sure that we've got those connections between our pharmacy commissioners and also our pharmacy providers in the local area, because I think that sounds like we need to just make sure that in terms of how those sharps are collected, that we've got some connection between our pharmacies but also with the waste team who are coordinating those collections. So I will ask that we pick that up outside.
Caroline, can you just confirm something though? The health waste team is not related in any way to the council's waste team. I was just thinking of the potential for another cross-cutting item.
When you say the health waste team,
well, clinical waste.
Yeah, so clinical waste would be picked up, for example, through our acute trusts, for example, manage their own clinical waste. But certainly for pharmacies, as I understand it, it's picked up through the local authority waste service.
All right, so I think that's another one for our list, Kerry. Thank you. Okay, I am sorry, I haven't written down anybody who was going to speak next. So has anybody got any other questions on the ICB paper? No. Thank you, Leslie.
Yes, thank you. It was about the ICB clustering. So can you tell us how the membership of that organisation is set up, and what the decision-making scope is for the place board?
So yeah, so the cluster at the moment is the Integrated Care Board cluster arrangement, which is Bain, Swindon and Wiltshire, Dorset and Somerset. So at the moment for this financial year, those three organisations are coming together in a cluster but still remain statutory separate organisations until there's a formal merger that happens, and those discussions continue on that process through this financial year. In terms of the place board itself, you'll see that there was some reference in the paper to the development of a place board for Baines. So this is a development on from the Integrated Care Alliance that operates at the moment, which has a number of partners around the table. So the proposal for that board going forwards is that it will have decision-making authority, and certainly for the ICB up to the delegated limit for the place director at the moment, which is 500,000. So it's expecting to be developed over the next few months. There are still some further discussions and conversations to be had about those place boards as they go forward, and certainly some further in the ICB itself as well, as we look at the place boards across each of the 6 current places. But the terms of reference for the place board are currently being developed at the moment, so they're still a work in progress. What the place board will also consider is its role in relation to this scrutiny committee as well. So in particular, if there are service changes or proposals, that they would obviously want to build quite a close relationship with the place board itself. And there will be a direct relationship, there's proposed to be a direct relationship between the place board and the Health and Wellbeing Board as well, because of the key role for the place board to be enacting the neighbourhood health plan going forwards. So the Health and Wellbeing Board will continue to retain its statutory responsibility around the health and wellbeing strategy, which feeds all of the plans locally and will feed into the place board. So I hope that's helpful.
Thank you,
It is,
Caroline.
thank you. Can I ask if councillors will sit on that board as well?
So at the moment, I think the councillors sit on the Health and Wellbeing Board, as far as I'm aware, but I think some of this is still being drafted at the moment, but certainly I think that's the position at the minute.
And you've also got councillors, usually the leader, who sits, I think, on the ICP, so the partnership as well. So it would be interesting to see how this continues to develop.
I was just going to come back on that point. So as part of the new guidance around ICBs going forward and within the 10-year plan, the integrated care partnership, that wider partnership will be dissolved going forwards, and the place boards will take some of those roles for that partnership development and decision making going forwards.
So I think there is going to be a question then about how does an elected representative, how are they included then in that new world? Because obviously the Health and Wellbeing Board, I don't think, is a decision-making body in terms of the ICB, although I'm sure their views will be sought. Leslie, sorry, did you have any follow-up question? Thank you. I think we're done with the ICB now, so thank you very much, Caroline. Oh, are we not done with the ICB? No, it turns out we're not.
Yes, sorry, it was following on from the discussion we had about the Cabinet member report. So I asked questions around the staff survey at the RUH, and bearing in mind that last year we were told by our management there were 1,000 less people applying for the courses, the nursing courses at UWE and at Plymouth, which are the 2 main centres in the southwest. And the survey results, some of the survey results, I've not got all of them, were around what seems to be a very poor, unconfident culture within the RUH. And one of the things that they said in the report was colleagues continue to struggle to meet conflicting demands, resulting in unpaid overwork, which is not a positive thing at all. But does the ICB have some impact there? Will the ICB raise some questions about that? Because this surely then reflects on service delivery to patients. And I've got 2 other questions as well.
Do you want to answer that one, Caroline, and then we'll come back to Leslie's last 2 questions?
Yes, absolutely. And I think there was also a request for the IUH to provide you with some information on an improvement plan resulting from their staff survey. So I'm very happy to pass that on to the IUH unless you're planning to do that directly. But just in terms of staff survey results and how we monitor those, with our providers. So obviously they are responsible for their staff survey results and the plans to respond to those, but we monitor those through our quality forums within each organisation and then at system level for Baines, Swindon and Wiltshire. So we were picking up individual concerns through that route.
Leslie?
Thank you for that. And also, I guess you won't have seen this, but back in October, I think, Kevin asked a question about the changes to the pharmacy at the IUH, where the process for delivering prescriptions to patients was being stopped, really. So have you had reports on how well that's working or how it's not working, what kind of impact that's having on patients? Thank you.
So I don't have details on that today, but I will certainly ask that question and we'll provide that in the next report.
Thank you, Caroline. I think you have one more question, Leslie?
Yes, it was something that I read that's saying that Health Watch is going to be disbanded. So again, that's a concern because Health Watch is made up of service users that then comment on the services being provided. And I wonder if you'd heard any more about what might replace it, if anything.
I think it'd be useful to have an update on Health Watch because I remember raising a similar point, I think, when the first iteration of the new ICB form was put forward. But I thought that that Health Watch was being kept, but maybe that's not true now. But maybe we should have a report on Health Watch. Yes, Caroline.
Apologies, I just realised I had my microphone on all the way through that, so apologies for that. So the NHS plan and sort of resulting guidance that has come out has confirmed that Health Watch will be disbanded, and that was included in the King's speech as well recently. So those responsibilities for engagement and understanding the needs and the voice and the views of local populations will fall to ICBs and local authorities. At this stage, there's still much to work through and discuss around that. So I don't have anything further to say on that at the moment, but the expectation is that those responsibilities will transfer fully to the ICB and local authorities.
I'm sensing a concern. Leslie, am I correct? Yes. Okay, maybe we could have some sort of update on the work that the Health Watch has done and also on how that new, how it will then fit within the ICB and ensure that there is still a certain amount of neutrality and whether or not that will still be in place under the next Prime Minister, I suppose. Anyway, anything else on the ICB? Right, we're now moving on to the next item, which is the Adult Social Care Residential Services inspection ratings. Alison, do you have anything you wanted to add to the report?
No, I mean, just to say that this is a very positive report, I think. You'll remember, I think we took these services back in-house in 2020, and there were a lot of challenges at the time, and we undertook to try to turn the services around and ensure that they were providing the sort of quality that we wanted. And it's not been the work of a moment. It's required a lot of sustained effort, investment in time, a lot of training. But actually, the services now are something that I think the staff working in them should rightly be proud of. So I'm going to hand over to Claire to take you through the highlights of the report. But yeah, it's very positive, and I'm really pleased about it.
Yes, and welcome to Claire. Would you introduce yourself, please?
Will do. Thank you, everybody. Claire Thorogood. I'm one of the assistant directors. I lead on our regulated services, so that's our adult residential services, and I also lead on governance. I just wanted to draw panel's attention to a few key points within the report. We last updated in November 2025, so today's focus is about giving some further feedback about the work we've done for both of our community resource centres, that's Cleve Court in Twerton and Coomley in Midsummer Norton, and outlining our ongoing commitment to improvement. Alison's already said it, but I think it's worth noting how incredibly proud we are of the BAME staff that work in our CRCs. The service improvement that they have and will continue to deliver has resulted in better outcomes for our residents and residents' families, and of course now we're striving for that more ambitious of we've improved, we've got to good at Coomley, we're now actually thinking about what is it going to take for us to strive for outstanding. With me today is Anne-Marie Stavert, our Head of Service as well. So Cleve Court was rated requires improvement. That's a score of 62%. That was 1 percentage point off. So we know the sustained efforts that we've worked towards over the last 3 to 4 years is working, and now that's about continuing that. And like I've said with Coomley, that's about striving for outstanding, and they move from requires improvement to good with a percentage point of 75%. When we had the CQC inspection in July with Cleve Court, it was the first time that one of these services had had that more relational support as well through having a care home inspection, and that enabled us to work really closely with the inspector team to do an action plan with that team. So I wanted to make sure that that was cited by panel. That's why that inspection report took a little bit longer to be published. We were working closely with that inspection team to highlight and give them the confidence and the assurance of the actions that we had been addressing with them in our week of inspection. I wanted to make sure on behalf of the team and the residents and the relatives, including the report as well, some of the really favourable, strong, positive comments, and those are in the CQC reports for panel to read, not just in the report to panel today. We do undertake a self-assessment each year as a service, and our strengths identified by ourselves are about the good and improving care standards, the responsive respite and place of safety offer that we have, the level of experienced, resilient management teams that we have within our services, and that strong community engagement and high-level professional intervention. Our continuous improvement ambitions, we have service priorities in 26-27. That is going to focus on person-centred care planning, our workforce development and supervision, learning from our audits in compliance and sharing that learning effectively across our services. And we still utilise the mock inspections that we have as one of the baseline activities as part of our continual improvements. We've had good interventions from our quality assurance colleagues in commissioning, and at Cleve Court in particular. At the same time as the July inspection, we had a visit that resulted in an action plan, and that's now been reviewed and updated 3 times since July, and the feedback is very favourable about the strong and continued improvements. We've also made best use of some capital funding, so the gardens are reopened to our residents and the families to use following the works on the retaining wall, as the balconies, and that means we have much better open space to make use of for activities and well-being. And at the moment there's a programme of work underway to refurbish, redecorate the residents' bedrooms in both CRC homes as well. And I wanted to mention climate resilience today is clearly a hot topic, pardon the pun. So we do have hot weather action plans in each of our services, but I'd already made reference to in the report Coomley is part of a climate resilience pilot, and we'd already identified for this year we wanted to be more proactive, and we're going to use that to generate a climate resilience plan for our services as well. And we welcome any questions now from panel.
Thank you very much, Claire, and welcome as well to Anne-Marie. Any questions? Michael and then Kevin.
Mine's more a comment than a question, really. It was just that, and I've already mentioned it, that I was very fortunate to have a chance to go and visit Coomley and Green Acres as well, and what a difference it just makes to get a better a practical understanding of how they've improved and what's been delivered there. So firstly to say thank you for looking after us so well when we were there. And it's great to have them in my own ward, and certainly to have the opportunity to go and see other adult services in my area would be really appreciated, because you get, it's one thing scrutinising the activities here in this room, but actually going and understanding it on a practical day-to-day basis is a really good way of understanding the challenges that we all face in improving quality of care for old residents in Baines. So, okay.
Thank you, Michael. I'm sure that is a very welcomed comment. Kevin.
Thank you, Chair. Well, first of all, thank you to you and all your staff and all the people that have done such great works. It's great to hear. A few questions. One around the role of AI in care, and always that goes with that, or with any technology, is the question of what happens when it breaks down, is unavailable, is blocked, is hacked, is whatever. Sustainability of performance, because obviously when you achieve that, good, which is good, being in the school sector, people don't seem to understand that good is good, is really good, it's more than just average, it's great. And the idea of then how to make those incremental changes and focus on improvement that doesn't burn people out. It's great to aim for outstanding, but there's also got to be on a spectrum. The fact that up there is great to aim for, but we don't always have to climb to the top of the mountain to get a good view and to get good quality things. So the other bit then is around the role of staff and what their role is in planning improvements in any changes. And you mentioned resident surveys. Do you do staff surveys, and how have been the recent results, and come back on that? Because in a time of change and rapid improvement, that's obviously one key indicator I would have thought to listen to. Your views around how you share expertise between residential care settings and succession planning, career development pathways. And finally, you mentioned climate change and buildings. What's the capital budget like, and is that sustainable?
I will do my very best to remember all of those questions. You may need to give me a prompt, Kevin. So let's take up the technology and use of AI. We have been fortunate where we have introduced a digital care planning tool into our care homes. That's been about a year in the making, and it does have AI functionality, but we are still asking our staff to input notes. But the AI functionality could be where people may choose to voice record some of those notes as well. So that's been a really good step change, and one of the things that's actually now underpinning our ability to demonstrate and record accurately the really good levels of care and personalised care. Now, that's not to say that you would ever be overly reliant on it. It's still about, isn't it, reflective practice of the practitioners, and making sure those practitioners are using it as a tool to make sure that we are giving all of those updates and all of the different activities that's contributing to that person's care. The beauty of it for me and for the management team is the better management oversight and reporting, and doing that ongoing checks and balances, where somebody like Suzanne, for example, could come in and look at some of the headline care records rather than having to go into several different folders, several different activities. So that's the stage that we are at with that. But I take on point your comment about AI, when it works, what if technology breaks. We're very fortunate we have a champion working across adult social care for our technology and digital agenda, and we've actually highlighted that as one of our areas of improvement for this year within our care homes. You have to remind me of the next one. I do apologise.
That's fine. I'll put the microphone on, sorry. I think it was around the sustainability of the next one, really, and the concern around how change is made from here and the pace of change.
Thank you. It's a marathon, not a sprint, I think, is the assurance I wish to give to panel. The level of change that we have done, as Councillor Bourne referred to, is we're in the midst of 5 to 6 years of investment and time spent supporting that momentum. My role as Assistant Director is to make sure that we have a plan and we govern accordingly to demonstrate how we do well-targeted, incremental support. I think you're absolutely right in terms of how it's sustained. So just to give a little bit of additional confidence to panel, I've actually worked for 30 years in further and higher education, and I'm well versed in Ofsted and regulatory planning. So one of the things I've been able to bring as Assistant Director to these services with Anne-Marie, supported by the whole management team, is how we plan well, how we prioritise well, and how we make sure it is realistic alongside the BAU, and we're there each day, isn't it, to provide that good quality care. Now, one thing we've spent a lot of time doing last year is making sure we take all the staff on that journey with us. So people understand, why do we need that change or a different approach? What is the intended outcome of that? Yeah. Measure it, what is the impact of it, and how we use that to tell our story going forward. Now, we've always had a CQC action plan or an improvement plan within our services. Anne-Marie and I have worked really hard with that management team to refine that into targeted areas with some really clear actions. We meet on a monthly basis. We have a dedicated meeting for our extra care services, a dedicated meeting for our community resource centre services, and we work with our registered managers and deputy managers about where are we at in terms of addressing that plan. Sometimes we might say that doesn't need to be a priority now for a few months. We've done enough work there and we could be more agile. So I wanted to give you the assurance that we take it very seriously. We might have the ambition of outstanding. It is never lost on me that that's not an instant thing. That's about turning continuous improvement into ambition. It's not about pushing so hard that it's not sustainable. The mission is sustainable improvement. We've worked so hard to get here. We don't want that to be lost easily over the next year or two.
Okay, so have all your questions been answered, Kevin?
No, we were just on to the role of staff, both in planning improvements and surveys, and any sort of issues that you wanted to highlight at the moment around staffing.
We don't have any major issues around staffing at the moment. That's one thing that's actually been the bedrock of some of our improvement. The management team have worked incredibly hard to recruit to some longer term vacancies that we've had. And that was in particular at Cleeve Court. But again, we have a very, very watchful eye on that. So when we have a dedicated recruitment meeting each month, dedicated time with HR business planners. So as we are preempting any staff turnover or how we manage, for example, maternity leave or planned leave. So the management team now are not reacting to, but being much more reaction in that sustainable workplace planning. We have a workforce development strategy for adult social care, and by virtue that's been adopted for residential services, and we have highlighted within that strategy there is more work and more focused work to be done about making sure those progression opportunities are there, but what additional training and support might be needed to enable that progression. And there's a longer term piece of work for me to do with Anne-Marie to plan for, in the next 2 to 3 years, some key post holders rightly choosing to retire after many decades of service in the care sector and with Baines. So we've already identified that, and work is underway for us to address that early, because it's not going to be coming as a surprise. We've got 2.5 years to plan for that.
Hopefully you won't need another 2.5 years to answer Kevin's questions. Are there more questions, Kevin?
There were just two, Chair. One was around capital expenditure budget, including particularly climate safeness, etc., and sharing of expertise amongst the various care homes and resources you have.
So at the moment, I have a capital budget that's still underway for the refurbishment. I cannot remember the exact figure. I would have to come back to panel and give that exact figure in, but that programme is underway. So that was dedicated spend for the refurbishment within those care homes. And we will be seeking to do some additional capital funding, and that bid will be going in the coming months, and we're working with the capital business partner for that to see if we are successful. So apologies, I cannot recall the exact budget figure. More than happy to go away and come back to panel to update on that.
And this is your very last question, Kevin?
Yep,
That
the
was an
sharing
instruction.
of expertise and how that's...
Of course it was. We have introduced more observations and reflective practice into our care planning. So alongside all the mandatory training and things that staff do, more time reflecting on that practice. And one element of the monthly improvement groups that we have together is registered managers and managers sharing some of the outcomes of that reflective practice in terms of the difference that it makes. So that's one sort of cultural shift we are making. There is still work to do. I think traditionally these services have been run very separately as separate entities, and part of that continual journey is we'd already recognised the sharing of the expertise. So that's about how we bring staff together to share in the prioritisation and share when we're giving the action plan feedback, the difference and the impact it's having and whether it should or how it should be replicated across the services. I don't think we're quite there yet, but we're already on that journey.
Thank you very much, Claire. And thank you, Kevin, for all of your questions. Les, I think you have a short question to ask.
I have a very short question, but I have to preface it with Claire, it's wonderful to see how positive and how committed you are. And so, you know, this service is definitely going to improve, whether it likes it or not. I'd like to concentrate on Cleeve Court, because I read the report, and it's very glowing in the way it praises the staff, and you and all people involved at senior management level have praised what's going on in both these two residential centres. But there are a couple of worrying things about Cleeve Court. And I know you've mentioned, I think Kevin has asked most of the questions that I would ask. But there were three things that stood out for me in the CQC report, and it was to do with staff. And I'll read it out. Staff lacked training and guidance to ensure consistent and safe care. The provider did not always ensure enough qualified, skilled and experienced staff, and training of support staff was inconsistent, leading to potential risks in care. And I believe this is why it didn't get the good. This is why it requires improvement. And I just wonder, because the last time it was inspected, it was a similar report. So have we moved on? I mean, I know you've gone into huge detail, and you're going to reassure me again, yes, you have moved on, but just a very short answer to explain what are you doing about training your staff?
Thank you very much, and your question is absolutely the right question to be asking of me sat here today. One of the step changes has been the change in the operational management of that care home. We were fortunate enough to recruit a new registered manager into Cleeve Court. That registered manager started with us last September, and that has allowed us to focus on the staffing. So we've always had a suite of mandatory training, compliance training, sector-led training, but the point is about making sure people attend, people understand, and that training then translates into good quality compliant care practice. So in short, the step change has been not just the ambition a head of service or an assistant director can have for improvement of services, it's the operational management and the good care standards that are installed by the registered manager, the management team and the seniors, and that's where we spent the focus and the majority of our time since September of last year.
That's fine, thank you.
Okay, thank you, Claire, and for the support from Anne-Marie as well. Okay, I think we're going to wrap that item up, and we're moving now on to the Suicide Prevention Strategy and Action Plan. Alison, do you want to introduce this item?
Just to say that this is an area that the public health team have been leading on for the last few years, and I think we've held 6 annual suicide prevention strategies. Conferences. We are halfway through the suicide prevention strategy, which runs from 2024 to 2028. And what we're presenting here today is the suicide prevention action plan for the coming year, for the current year. So I'm going to hand over to my colleagues in public health just to take through the key points of that. So thank you.
Thank you. So Celia? Would you, is there anything else you wanted to give in addition to the report before us?
No, nothing else.
No. Thank you. Okay, thank you. And then we will then move into questions unless Paul wanted to add anything. No? Okay. Right. So I saw Michael first and then David and then Kevin. Michael, you can start off.
Yeah, the one stat that really jumped out for me was the 18 to 24-year-old self-harming stat that had gone up. So the Baines was significantly higher than both the Southwest and national average across them. That's a very good, and I understand we had a similar stat sort of last year, and I didn't know what had been done to improve that, and what are we doing to try and identify why more younger people want to self-harm, and what can we do to discourage them from doing that? Yeah.
Thank you. So this figure has been high for a number of years now. So there's been several things to try and unpick the reasons underneath. So currently, in the past year, Healthwatch has been doing some pieces of work around self-harming and young people, and equally, BSW are currently leading on a piece of work to try and understand more. So it's not clear at the moment still, so we're looking into that. But one of the reasons that has been explored is the RUH being very responsive, and work that has been done in the past to make sure that anybody that accesses hospital is admitted and looked into, which might differ from other areas, but that's an ongoing piece of work, and I'm sure once it's finalised, the results would be brought here.
David.
Thank you for your report. Could I ask two questions, please? One's about the Equality Impact Assessment, item 3.12, rural communities. And you talk about access barriers in rural areas mitigated through digital access and community networks. I just wondered what those community networks were.
So the strategy we have in Bath and North East Somerset is the foundation of that is that suicide prevention is everybody's business. So the way we're approaching it is that everybody has a responsibility to look after each other. So in terms of community organisations, it goes as wide as it could possibly go. So the training is available for all the community and all the workforce within Bath and North East Somerset, and the expectation is that people would then own that and follow the strategy.
Who are the people?
So when the people, sorry, can you specify?
GP practices, parish councils. Who are the groups in the community that are being used to mitigate?
So the training is available for everyone within the community. So within the way we have the strategy, and then every year we develop an action plan. So the people that take part in the action plan normally tends to attend the stakeholder event that we run yearly. So last year we had 100 people attending the event, and from 30 different organisations. We have a report on that we can share. But yes, as you rightly said, we have housing association, mental health services. We'll have primary care services. We have representation from secondary care as well, and ICB. We have community organisations, parish councils. There's a real wider, and both for young people and adult services as well. it goes as wide as colleagues from libraries, for example, also take part. So it's a wide representation.
David, could you, if you're not asking a question, turn your microphone on? Because I think your microphone was a little bit quiet. Is that the end of your question, David? Is there a group that you feel should be included?
No, I just wanted to know how the access barriers in the rural communities were being improved, really. My second question is, how long does it take someone who has got severe depression to actually access talking therapies, if that's what's appropriate? And are the waiting times for this going up, down, staying the same?
It might not be a very helpful answer, but because those services are commissioned by our ICB colleagues, and I don't know if Caroline would necessarily have the
Sorry,
answer.
Paul, have you got your microphone on? Yes. Oh,
I think
okay.
I do. Is it working?
Yeah.
Maybe I have to get very close to it. Those services are commissioned by ICB colleagues in the NHS and our mental health commissioning colleagues. So I don't know if you would know any of those answers for Baines, Caroline, but we can certainly find out the answers about that kind of access. I mean, I guess it's a range of things as well, just so the talking therapies, but there are other routes through our Community Wellbeing Hub and our Wellbeing services, or even to secondary mental health services through their access team. So there's sort of a number of points in, but I'm sure it will be ICB colleagues who could answer some of the waiting times.
I hope you can hear me. I don't have that detail on me today, but I'm very happy to provide a written response, so happy to pick that up afterwards.
Thank you. It'd be good to know if they differ from different routes of referral, self-referral through the Wellbeing Hub, or via a GP or A&E or whichever. Thank you.
Actually, and within that, could we also have some reference to CAMS as well? Yeah. Because I think historically we were all aware that CAMS referral rates are quite slow. Liz, were you next on my list? Would you like to be?
I don't know if I'm next, but I'll certainly jump at the chance to be, so thank you. I mean, this is a very difficult subject, isn't it? Suicide, and it's so personal when this happens to someone, and it's good that we remain below average, which is good to note. Is there any? Do we know why we do this? This is my first question. Have we got sufficient things in place that we achieve a lower rate and we are below average, which is good, and can we build on this? The other thing I wanted to know is, from various groups, do we know if there are persistent sticking points that could be, I'm not sure exactly what these might be, but could there be? And my third question is, emergency hospital admissions are significantly worse in Baines. Do we follow up on, I suppose this is not quite a question for you, Paul, but do we follow up on these admissions? Because emergency hospital admissions of themselves say that it's a cry for help, and either they have been prevented in time or whatever. So I just wonder about that. Do we follow up? And I know we're looking at targeted groups to predict where certain things might happen, but I just wondered, is there some follow-up to this? And my fourth question, sorry, I didn't mean to have so many questions, but we've seen on the media that many young people, especially young people, see instructions, information about how to commit suicide online. Is there anything we as a council can do about that, or is it just the fact it's on social media and there's nothing we can do? So sorry about that. 4 questions. Thanks.
Okay, thank you for those questions. I'll try and answer to the best I can on those various things. So on the first one, in terms of why we're low, it's always really difficult to take account for, you know, a population outcome like our rate of suicide. But what we can do as a council, with responsibilities for suicide in the population, is make sure we have a plan in place which follows the national strategy, which we do. So we have a good understanding of our figures, and Thalia commissions with other colleagues in the Avon area real-time surveillance program. So we know really good information about when deaths have happened. That allows us to then understand risk factors that we may be able to take action on from those deaths that have happened. It also allows us in very quick time to offer bereavement support to affected families, which is a really important part of the national strategy, and reduce risks for those people. We work with all those third sector and other community groups, like Thalia said, in terms of training and improving people's confidence to have conversations with people in the community when something's raised. Our part of our suicide prevention strategy group has the universities, including Norland, including Bath College, and they've got a really proactive working relationship around suicide, given there's so many young people. So we have a range of all those sorts of actions in place. That's all we can do to some extent. And also try and sort of hold the secondary services to account. Oxford Health, Avon Wiltshire Partnership, are they putting their own more internal acute trust type relationships, plans in place? In terms of hospital admissions, I mean, I think Thalia answered that point about why they might be higher, but there is work that will be done for people, and we have tried different projects over the years in terms of how you support people. Some people go to the emergency department having self-harmed. They may have taken an overdose. They may have cut themselves, for example. Some people won't even stay until they're seen. So we've tried information packs in the past, so people go home with something that can help them and their families, perhaps. There needs to be liaison afterwards. People often present out of hours overnight, for example. So it's what information can be given to the GP so that they might be able to follow up and point people to the most useful source of help. So there's a variety of things there that is all part of those constant having to kind of improve those pathways as people change. In terms of sticking points, I mean, there's a variety of things that we know are higher risk groups in the population or higher risk issues, which could be things like financial debt or loss of work or relationship breakup, substance use. And those are all the kind of focus of our ongoing work with those partners. So I hope that's a helpful answer.
The million-dollar question, what can we do about social media?
Oh, yeah, sorry. Well, there is a limited amount I think we can do as a council in terms of tackling those national online harms that we see with things like the new ban around social media. That will have some effect for children, and online safety does feature as part of obviously schools work strongly these days, so for young people, but there is a limit, I think, really what the council can do for adults in terms of accessing that. When we hear reports of that or it comes up through a death, we do report it, don't we, through our Department of Health and Social Care colleagues at Region, and they will raise things nationally, but there is, and we have the police involved in our kind of group as well, don't we? So we try within the limits, but we don't really have much power around it. Is there anything else to say, Thalia?
No, just to reiterate, so we work very closely. Police are part of our strategic group, and any reports we get, then it would be taken up with the police, and they do have a national team. So as we do everything that is within our power, which is to really escalate that through the appropriate channels. And just to add to the sticking points, part of the real-time surveillance that Paul was explaining, where we do monitor any suicide deaths within Bath and North East Somerset, then part of what we do with that is we analyse the data, and we do that in time, but also within the previous 12 months. So every year we have a report where we look at our priorities, but we compare that with any themes or anything that is emerging. So, for example, last year we did a piece of work around climate and suicide and how hot weather affects people with mental health and the links with suicide, because we saw a higher rate through the summer months. So then what that meant for us is that we're now working with our colleagues to make sure that any heat alerts, anything like that, then is linked with that. So it's a live piece of work, and it's continually evolving. Thank you.
Okay. Are there any other questions? Leslie and then Kevin, and then I have some questions too. Leslie.
Yes, thank you for your report. Not quite sure where to start with this. I think I'll pick up on David's point about rural communities. Again, while I was at the Somerset Cricket Ground on Friday, they were having a support for Farmers Day, Wellbeing Day, which was really interesting. I was talking to the people on the stall, and they were saying that the rates they have are very high for farmers, which is something that we've talked about before. And there is an area manager that covers us as well as Somerset, and they would be quite happy to come along and talk to officers in the first instance about the things that they're seeing. Because they were saying they'd had a young farmer passed away quite recently through this method, and they're seeing younger people, not older people. And this is back to what you've just raised, Paul, about the financial pressures. Having said that, I mean, do you have the card? Having said that, there's lots of groups of people who are more likely to be affected and unfortunately go down this course. So, for example, among men, it's quite often the highest group is construction workers. Women, it's care workers. And women also, people that work in the creative industries. You know, again, they're probably working in isolation rather than in general areas. There's loads of information on the web if you want to have a look at it. What does concern me a little bit about this plan, that the only targeted intervention I can see is about enhanced support offered to middle-aged men. And I think it probably needs to be a bit wider than that. The Diversity Trust, I understand, has funding to work with LGBT plus people. Again, a highly susceptible group. So will you be looking to work with either local LGBTQ plus organisations or Diversity Trust, because through them you can get links into there. And I think that would be a really important thing to do. The other link for me is with self-harm. Quite often self-harm is linked back to ACE people, those with adverse childhood experiences, and then that links us back into social services and spotting that. Again, this is linking back to another service, but it needs to be brought together. What I'd like to see in the plan is a definition of some KPIs, some delivery timelines, some reporting cycles, and a performance dashboard, because I think we've got a nice plan, but I don't get a feeling that we've got anything proactive coming out of it that we can look at as a scrutiny panel and say, this has worked really well. And I recognise it's really difficult. It's not an easy area to work in. It's a very stressful area to work in. And the other thing I'd ask, and probably, Paul, you can't answer it, but it probably needs to go somewhere else. What resources do you have? What funding and staffing and capacity have you got that can be allocated to delivery actions? And if you don't have those, then what are going to be the consequences? Thank you.
Thanks. I can try and answer maybe just some of those, relate to some of those. So the focus on middle-aged men comes from the national strategy, really. We still know in Baines as well, it is our highest group. So that's where we see our highest risk. So I definitely take your point. There's other groups as well, and they are included in the action plan. So we do consider all sorts of routes, including occupational risk, and we look for that quite closely in our real-time figures. The issue of trauma during childhood is a really important risk factor for us, and that's brought out through our sort of closer links with children's services and is a really important part of things like our Best Start in Life work. So it kind of integrates it into those other big plans and strategies, including the meeting that was mentioned earlier around children and young people's emotional health and well-being, and the summit that the ICB and the Council and others are working on. Those are the best routes to be looking at how we can improve mental health for young people or for adults and so on, rather than creating more and more suicide prevention specific things. It's more about building those good access to mental health support and so on. So that's something about that part. We'll take your comments away. Those are helpful reflections about whether we need some more specific kind of key output and outcome measures from the action plan and something that can be tracked more easily. That's a useful reflection. We have a dashboard. We do have a suicide prevention dashboard. Did you just want to say something about that?
Yeah, just to say, so last year what we work on, we do have an action plan that is with all the different partners where they have the actions that they would take. A lot of those are business as usual for them, so it's the practice that they do normally. But the feedback we had previously was that they wanted more visibility on some of the new pieces of work that were going to be done. So on the back of that feedback, we then we had the strategy already for the public, but we created the strategy on a page, and then on the work of the 26-27, we then had this accessible for the public with the key actions that are new, but then obviously behind this there's a whole piece of work where there's a lot of business as usual items. So 3 years ago we had all the actions in the action plan. We weren't able to share any of that with publicly because some of the detail in those reports. So this is almost like that evolution. So there is an action plan behind with a lot more detail, but this is what is shared with the public. So we do, there's actions specific to LGBTQ+, there's actions for new parents, maternity wards, there's a wider piece of work that falls within lots of different services, business as usual, that take suicide prevention as one of the approaches to the normal practice.
I think there was a final question about resourcing, which is a good question. The resourcing that we have is purely in terms of our staffing capacity. So a small proportion of Kathy's role, a small proportion of Thelia's role, and another more junior officer's time. And that is about bringing people together, identifying these issues, commissioning some of those things like bereavement support, real-time surveillance, doing what we can to have an action plan in place and have a good oversight, and then really work with our partners to make sure they're fulfilling their responsibilities. There used to be some more funding from Department of Health and Social Care, but that did all stop a couple of years ago, so we don't have any dedicated national funding other than the very small amount of resourcing through the public health grant for our work to coordinate it.
Thank you. Okay. Kevin, did you have questions? I can't remember if I'd already asked you. Okay.
Thank you, Chair. 2 questions, and really around the area of the self-harm injuries in that age group 10 to 24. First question is around really what particular strategies within schools are you supporting or targeting on your dashboard, both at secondary level and primary, and that could also be in terms of support services around schools, and what work they're doing and how they can improve their support. And the second thing was around the excuse me, the RUH pilot, who I think was mentioned a few meetings ago now. But there was a youth worker involved in the RUH for under admissions and would talk to people if they wished to be talked to or with, and how that tied in with your current strategies, and whether that's going to be expanded or whether it's working well and how it's working. And the final thing wasn't a question but around a comment really, and was thinking about in terms of your sort of most of the planning being, or sort of reports being around, you have to sort of retrospectively, if you like, analyse the situation, which is not very helpful, not very nice for you either. But you're looking backwards as opposed to what you're planning forwards, and whether in the Southwest you're part of a group of councils that are sharing practice and saying what works.
Sure. I'll just answer that last question first. Thalia or another colleague will join a kind of regional approach to kind of just keep in touch with other local authority leads on suicide prevention to make sure they're all just, you know, sharing good practice and so on. In terms of that forward-looking and backward-looking, the real-time suicide surveillance is it's like a national program. We work with the Avon Coroner and Avon and Somerset Police, so we will know if, for example, there was a death today. We would know in the next 48 hours, sometimes sooner, you know, sometimes it takes a bit longer. We would know about the death, and then we would start to gather a tiny bit of information about it there and then. So if we can start to spot there appears to be, you know, a number of deaths in a location or amongst a particular group, for example, a university, we would be able to take action very quickly before having to wait too much longer, and we could try and, Thalia and the team would try and gather some more information. But once we have, it obviously takes quite a long time. For a coroner, it may take several months to reach a conclusion following an inquest. So once we've actually got all the information back, a cause of death, toxicology, things like that, we then look at that for more strategic themes. So we have the kind of forward look from the, you know, we know from the national plan those key groups and the key risk factors. We know those already, and that's what we plan for. And then we can alter them with our look back once a year or even once a quarter and just think, here's an issue that seems to be more locally relevant for us. And then we have that immediate kind of on the spot, week by week, is there an issue arising? Do we need to do something specific? And because it's Avon-wide, we can compare with partners in case there's something around a border or particular locations. So that's probably that bit. In relation to the bit about young people and work with schools and so on, I don't know almost whether it would be better to give you an update through the children's panel meeting that could link with some of the work going on in terms of the emotional health and well-being. But there is work that's on the hub, which is public accessible, the website, the schools hub. There's loads of information about mental health in schools and about how to work with young people. There has been work through Oxford Health that they did lots on using their harmless tool and things like that, and how to support teachers or other people to work with a young person who has disclosed that they've harmed themselves, because often that person who's a trusted adult might be the best person to work with them, identify just what the risk is, and then form a plan, even if they then go on to refer into Oxford Health. At least there's a plan and some immediate safety planning around it. Is there anything else to say around kind of work with schools or young people you just want to mention?
Just the work that happened within the past 2-3 years, where every school had members of staff trained to have a mental health lead to be able to support all the staffing within the schools. So that network is still up and running.
Okay, I have a few questions of my own. Trying to work out the best way of phrasing this. How do you capture the causes that might have driven somebody to commit suicide if they then don't? But obviously there will be a factor, it could be a factor behind other potential deaths. I mean, it's because none of the partners you've listed, I think, would be natural bodies that would capture that kind of information.
So I think, yeah, you do answer that.
So because behind every death there's a real complexity, and every case is very different. So the way we capture that information is through our bereavement service. So they work with all the families, and they work with all.
I'm talking about people who don't end up committing suicide, those that might have all of those same drivers but then don't.
Okay, sorry, I misunderstood the question. So for that case, we obviously have the national strategy would highlight what the key risks are, which is what Paul covered earlier in terms of relationship breakdown and economic disadvantage or other vulnerabilities. So that would be the common risk factors that all the services, not just mental health services, but wider services in the community would target to support.
It just struck me that they would be a very powerful group if it was possible to group them in order to help with the strategy.
So we do have experts by experience that then input in the strategy, both within the BSW strategy and the refresh that we did on the back of that for the Bath and North East Somerset, that would bring together some of that experience and input.
And then I just wondered about capturing another group's views, and that's survivors of child abuse, which you've spoken about childhood trauma, but I wondered again about a group that may or may not be being represented within the partners that you work with.
It's a good suggestion, and we could take that away. I don't think we have a specific answer for that now, so it's a good suggestion. We could look at taking that away.
Okay. And I think I'll come to you in a moment, Kevin. Do we want to see, I mean, this is a strategy which I'm sure that we welcome, but there's obviously areas that we would like more consideration on. Do we want an update before the next strategy comes to this panel? Perhaps in Alison's next report we can have just some sort of update from the on this. Yeah. Okay, Kevin.
Yeah, thank
only
you,
if
Chair.
it's a small question.
Yes, it was really building on your point, which I didn't think Paul may not have forgotten in the list I gave him, but he was asking about, I asked about the RUH pilots, about the youth worker working with admissions around self-harm and other things that may happen, and how that was going and what data is going back to you.
That's a good question. I'm not actually close enough to it, to be honest, but I don't know if Ellie, whether you know about that specifically, or it might be something we'd have to ask someone from our Children and Young People's team, or whether it was commissioned by the ICB, possibly, I'm not sure. So we'll have to get back to you if that's all right, with something a bit more specific about that. I know we've had work on safety planning in the RUH with Bath Mine previously as well, but more for adults. So I'll happily get back to you with some more information about it. Sorry, I haven't got an answer right now.
Well, thank you, Paul, and I think this is always a very difficult subject matter, so I think it's been dealt with very sensitively, but I'm sure it is always more work that can be done, and I guess going back to my points, it would be great to not have to look at something that has happened, but to be preventing, wouldn't it? Yes. Okay. Because we obviously don't know how many suicides have been prevented unless they are reported as such. Okay. Right, I'm going to move us on to our very last paper, but thank you very much for everybody who's contributed to that item. So, well, when I say the last paper, it's the minutes of the last meeting. Are they broadly a good reflection of everything that happened, apart from the bit that Kevin's going to pull out now?
Thank you, Chair. I think Mark only did it to see if I read the minutes, but on page 10, on the third paragraph, if it is me, it's my name spelt wrong. It says Kevin Bennett, I think, the first time on that page.
Well, he also turned up. Just amend it, Mark. Okay, apart from Kevin Bennett, is there any other issues, anything else that was incorrect? Otherwise, are you happy to say they're okay and good? Lovely, I'll sign them in a bit. The work plan, obviously we've got a lot of other things that we've spoken about during this meeting. Is there anything else that we want to add to the work plan? As usual, if there is anything, then please contact myself and Kerry and Mark to add, and I will make sure that we have the RUH/BSW hospital trusts in the room for our next meeting. Well, we'll certainly be invited. Okay. Anything else at all? Lovely. Well, thank you everybody for staying to the end. It's not been as hot a meeting as I thought it might have been, and I look forward to your presence at our next meeting. So thank you, and it's, I think, good afternoon.